अस्सलाम वालेकुम। आई एम डॉक्टर सबरीन सलीम फ्रॉम हैरिसन फिजिक्स एकेडमी। मेरी सिर्फ तमाम जितने भी स्पीकर्स हैं उनसे एक रिक्वेस्ट है कि आपने अपनी प्रेजेंटेशन शॉर्टेस्ट रखनी है, ठीक है? जैसे चेयर को चेयर आते तो हम ये सेशन स्टार्ट करते हैं, लेकिन हमने इसको खत्म करना है क्लॉक से पहले, ठीक है? आपने अपनी प्रेजेंटेशन कोशिश करनी है कि 10 मिनट्स से ज्यादा ना। थैंक यू।
मिले कि नहीं? वहां से क्लोज होगा ना, 6 पे करना। डीपी लॉन्ग में होगा तो 15 पे रखना, ठीक है? 6 पे जब जाओगे ना तो क्लोज पे जाना। क्लोज जब जाओगे ना तो लेट काम हो जाती है। ये देखो अब सही लेट सही आ रही है लेट। ये देखो काला हो गया है, ये ठीक है लेट है, ठीक है? फास्ट जब आओगे ना 3 पे आ जाना। वैसे भी यहाँ से फिर ये भी बढ़ जाएगा, ये यहाँ पर सही कर लूंगा जैसे। तो पर्चे मैंने खोला हुआ है ना, फुल खोला हुआ है ना। जब क्लोज होगे ना देखो काला हो जाएगा ये, ठीक है? अब साथ ही 6 पे डालना, थोड़ा सा निकल के आएगा चेहरा। 12 में मैंने रखा, 12 में नहीं जाना। तीनों 6 पे खेलना है आपने, ठीक है? हाँ 3 पे रखो, यहाँ पे 3 ठीक है। क्लोज पे जाके 6
अस्सलाम Respected chair, dear participants, speakers, and students, Assalamu alaikum. I'm Dr. Samleen Salim, Associate Professor, Health Services Academy, and I'm serving as a moderator for this section. The topic of our scientific session is health system strengthening through innovation. So we are going to start this session. So, dear sir, our respected chair is here, Major General Salahuddin Qasim, Imtiaz Policy Board Chair, Khyber Pakhtunkhwa. Dear sir, should we start the session? Okay. So, we will have some words from you regarding system strengthening through innovation. So, what do you?
So we need to be part of HSA and
Silence, please.
we are already late by our session, so I think we will start quickly as the case possible. So what do
Professor Dr. Iqbal Hussain Dogar is our keynote speaker for today's session. His topic for presentation is clinical application of ALARA principle in pediatric CT imaging to avoid unnecessary radiation. So please start.
How we can prevent the radiation, because the radiation can affect populations, especially when used in the diagnostic as well as for some therapeutic purposes. So the main purpose of this presentation is that how we can avoid and what are the different ways of avoiding the radiation, ionizing radiation, which are harmful to the patients. So I have no disclosure for this presentation. Outlining principles of ALARA, then objectives of ALARA, application of ALARA, key principles of ALARA, risk of radiation in pediatrics, implementation and recommendations of ALARA. Next, please. So what is the LARA? LARA is basically as low as the reasonably achievable. उसका मतलब ये है कि आपने कोशिश करनी है कि reasonable तरीके से जो है low कितनी हम जो है वो कर सकते हैं, ठीक है? So objectives क्या है? We want to minimize the radiation dose exposure to patients. Patients can be pediatric, any patient. उसमें कोई डिस्क्रिपेंसी जो है ना वो नहीं है। पीडियाट्रिक पॉपुलेशन हो सकती है, एडल्ट पॉपुलेशन हो सकती है, but we are more focused in the pediatric patient because they are more prone to have these hazardous effects of these ionizing radiation. Then healthcare workers are also very important. The healthcare workers maybe primarily which are doing the procedures, especially working in the radiology department, and then other workers which come in the radiology department for assisting the patient. So we should also be very careful. Then general public, our concern is also that we should not give any sort of radiation to general public as well. So application of LARA is basically, it is used in the medical imaging, then sometimes it's used in nuclear power plants and industrial radiography, maybe even use of it. So two key principles इसके जो ना है, one is the justification and the second is optimization. Justification basically ये है कि when we advise any kind of investigation, which is the ionizing radiation. Ionizing radiation number one is X-ray भी आता है, number two is CT scan भी आता है, number three is fluoroscopy भी आती है, number four is जो angiography, deep subtraction, angiography and nuclear gamma cameras हैं, इनको advise करते हुए there should be definitely 101% justification. If physician does not give any justification, it may be sued. अगर उसको कोई भी प्रॉब्लम हो जाती है. Number two, optimization. When patient came for any diagnostic purpose, it is responsibility of the radiology department or the tech or the nuclear medicine department that they should optimize, that we should give the radiation as low as possible. So optimization is the second most important thing. Pediatrics are the most because children are more they're developing organs, they are developing tissues. Then importance of minimizing radiation in the pediatrics because they are more prone and there is also going organogenesis. Especially we should avoid radiation in the pregnant patients. उसमें तो बिल्कुल ही जनाब अगर आप करते हैं तो इट मीन्स के अगर आप किसी डेवलप कंट्री में कर रहे हैं तो आपको फ्लू जो है ना वो डेफिनेटली हो जाएगा एंड यू मे बी इन डिफिकल्ट पोजीशन फॉर योर इवन लाइसेंस. Then tailored application pediatric setting से आप pediatrics में कर रहे हैं तो आपने setting ऐसी करनी है, machine की setting ऐसी करनी है, आपने machine के protocols ऐसे develop कर लेने हैं कि जिससे as low as जो ना वो patient बच्चे को जो ना radiation मिले. Then ensure adequate diagnosis. लेकिन एक चीज और भी बड़ी जरूरी है कि we should give the diagnostic information proper. ये ना हो कि हम डोज कम कर दें या हम जो है ना वो जस्टिफाइड ना करें लेकिन पर्पस सर्व ना, पर्पस भी सर्व होना जो है ना वो बड़ा जरूरी है. Then why the increase क्या रहता है रिस्क हो सकते हैं पेशेंट्स के अंदर जो स्पेशली इन पीडियाट्रिक पॉपुलेशन. Then another thing is very important that we may have genetic mutation in these patients, so we should be very very careful. And long term effects भी जो है इसके हो सकते हैं especially in the pediatric population. और psychological impact जो है वो भी definitely जो है वो होगा. मतलब जो है वो अगर बहुत ज्यादा ही मिल जाए इसके parents जो है वो concerned होंगे. Implementation of the LARA principle, justification of CT scan as that before, then we should develop the protocols of for optimization. Then individual dose adjustment, this is another third important. कि फर्ज करें एक मोटा बंदा है तो उसको जरा रेडिएशन आपने ताकि उसकी जो क्वालिटी ऑफ इमेज है वो भी हमने जनाब मेंटेन रखनी. देन अल्टरनेट इमेजिंग मोडेलिटी कौन कौन सी जो है ना उसमें अल्ट्रासाउंड है, एमआर है, ठीक है, ये दीज आर द अल्टरनेटिव मोडेलिटीज व्हिच वी कैन यूज व्हिच डोंट हैव द आयोनाइजिंग रेडिएशन इफेक्ट. Then radiation awareness and education seminars जो ना होने चाहिए, dose monitoring, quality assurance जो ना होने चाहिए, and integration of the strategies. Just justify CT scan जो ना as I already told, then optimize protocols, individual doses, then consider non-ionizing alternative, prioritize ongoing education. So हमने जो study की वो क्या थी basically, it was a prospective study and showed patient confidentiality. Our study was by guidelines by the HIPAA guidelines. Patient informed consent was done, then assured पेरेंट्स ऑफ नो हार्म। हमने बेसिकली इसकी मेथडोलॉजी क्या की कि हमारे पास जो बच्चे आते थे, दिस स्टडी वाज डन इन चिल्ड्रन हॉस्पिटल, के हमें जो है ना वो पीडियाट्रिशियन भेजता है, जब पीडियाट्रिक सर्जरी वाले भेजते हैं, एक स्कैन करते हैं, वी गो थॉरली के उसकी हिस्ट्री सारी देखी, इट्स जस्टिफाइड और नॉट, और फिर हमने देखा कितनों को हम जो है ना अगर अल्टरनेट कोई मोडेलिटी एडवाइस करते हैं तो वो एक्सेप्टेबल हुई, ठीक है। उसका थोड़े से जो है रिजल्ट्स आपके साथ जो है शेयर करना चाहूंगा। स्टडी डिजाइन है, देन इन्फॉर्म कंसेंट, पार्टिसिपेंट सिलेक्शन जो है ना वो 14 ईयर से कम ईयर के जो है ना बच्चे थे, ये 2 मंथ्स में जो है ना वो स्टडी हमने कंप्लीट की। सैंपल वाज 151 और का स्क्वायर जो हमने इसमें अप्लाई किया चिल्ड्रन हॉस्पिटल में हुई 14 इयर्स में। 91 वाज मेल, 60 वाज फीमेल्स, एज लेस देन 1 month 3, 1 month to 1 year 19, 1 to 3 years 46, then 3 years 83, outdoor patient 38, then indoor patient 103, emergency patient 10। रिजल्ट्स जो है वो हमारे क्या थे, 139 farms had a complete patient history। दूसरे जो 12 केसेस थे उनके हमें एडिशनल इंफॉर्मेशन जो है ना लेनी पड़ी, जो भी परफॉर्मेंस है उसका था। Then CT brain 73, without contrast 43, with contrast 30, chest 35, abdomen 14, then temporal bone 3। ये उनकी कैटेगरीशन थी जो हमारे पास रिक्वेस्ट जो है ना वो आई थी। अब हमने जो परफॉर्म किए ऑप्टिमाइज जो है ना वो किए 9 फीमेल पेशेंट 10 मेल। ये वो पेशेंट थे जो हमने कहा कि इनको जरूरत जो है ना वो नहीं है, ये हमने अवॉइड कर दिए, ठीक है। सो टोटल 19 हमने पेशेंट जो है ना अवॉइड कर दिए। उनको अल्टरनेट हमने ये दिया कि या इसका आप अल्ट्रासाउंड कर लें, या इसका आप जो है MRI कर लें, या इसका जो है इंटरवेंशन प्रोसीजर कर लें। और 4 पेशेंट वो थे जैसे किसी ने एडवाइस कर दिया कि आप सीटी ब्रेन चेस्ट ऑफ जैसे मेलिग्नेंसी वाले पेशेंट्स होते हैं, कैंसर वाले, उनको लोग लिख देते हैं नेक चेस्ट एब्डोमेन सारा कुछ जो है ना वो करते नहीं। हमने कहा जी अगर जरूरत एब्डोमेन की तो आप एब्डोमेन का, सो वी ऑप्टिमाइज दीस पेशेंट्स। 4 हमने जो है ऑप्टिमाइज किए, 19 को हमने जो है ना वो कहा कि इनको जो है ना वो जरूरत नहीं है। सो इट वाज अ गुड स्टडी एंड नाउ वी आर आल्सो डूइंग दिस स्टडी इन गुजरांवाला मेडिकल कॉलेज, but now our sample is more than the 500. So our the recommendations. So next so recommendation justify the need for CT scans, number 1. Number 2, optimize imaging protocols, and number 3, individualize radiation dose. The next next. So this is important recommendation में हमने consider alternative imaging modalities, then communicate effectively with patients and families। but families को जरा बात आता वो क्या होता है, बात है नहीं जी डॉक्टर ने तो लिख दिया कि ये सारा करवाना है तो आप क्यों कह रहे हैं वो। so communication with this family is very important। then provide radiation awareness and education of seminars जो ना वो करें, professional training अपने लोग भी जो ना वो करें, उसके बाद dose reduction strategies जो ना वो अपनाएं। मॉनिटर रेडिएशन एंड क्वालिटी एश्योरेंस, ये है कि आप जो डिपार्टमेंट के उनके प्रॉपरली जो है बैजेस हों, उसके बाद जो लेड शील्डिंग या रूम्स की प्रॉपर हो, उसके बाद अगर फर्ज करें आप किसी फीमेल पेशेंट का जो है वो कर रहे हैं तो उसको प्रॉपर जो है ना उसकी शील्डिंग हो, शील्डिंग इज वेरी इंपॉर्टेंट। बल्कि आप में से अगर कोई किसी ने बच्चे का करवाने जाता है तो वो स्पेशली जो है ना वो गोनेड्स को जो है पीडियाट्रिक्स में गोनेड शील्डिंग इज वेरी वेरी इंपॉर्टेंट। जो ना ये टेक की जिम्मेदारी है वो प्रॉपरली जो है ना गोनेड शील्डिंग पीडियाट्रिक पेशेंट्स में जो है ना वो करे। और एक हम वर्ड यूज करते हैं कि एरिया ऑफ इंटरेस्ट, ये नहीं का ये करना है जहां का, और एरिया ऑफ इंटरेस्ट आप बहुत ज्यादा जगह रखते हैं। सो दीज आर द मेजर वी शुड टेल टू आवर पॉपुलेशन। थैंक यू वेरी मच। थैंक यू।
Thank you, Dr. Iqbal. Very informative और especially जो take home message है वो यही है कि we should be very careful about asking for radiation, specifically ionizing radiation diagnostics. और naturally जो दो की वो है infants and mother. So उनको का बड़ा ख्याल करना है आपको तो चूंकि children पे की है hope so कि हमने किसी stage पर हमें एक study ये भी करनी चाहिए मदर्स को जो कि एक्सपेक्टेड मदर्स जो हैं प्रेग्नेंट वुमन कितनों को रेडिएशन लोडेड डायग्नोस्टिक्स एडवाइस होती है थैंक यू
जी जी
Sir, my name is Dr. Davarsh. I'm a medical service. I'm also doing investigation. So my question was that आपके उसमें आपने कहा कि total around 130 से 19 का है
151 पेशेंट है 19 बोलते हैं जिनको हमने टोटल जो है ना रिजेक्ट कर दिया कि हमने ये करना ही नहीं है सीटी
जो आपने रिजेक्ट किए सब में मेजर क्या चीज थी?
उनमें उसमें ये देखें अगर फर्क करें मेरे पास जो है ना वो भेज देते हैं जी इसका सीटी हेड का है ठीक है अब मैंने देखा कि इस बच्चे में आप सीटी हेड क्यों करवाना चाहते हैं अगर तो ट्रामा पेशेंट है फ्रैक्चर है तो डेफिनेटली 100% सीटी करना पड़ेगा लेकिन अगर आप हाइड्रोकेफेलस देखना चाहते हैं या आप देखना चाहते हैं कि उसकी जो है हेमरेज है तो अल्ट्रासाउंड पे लेस देन 1 ईयर में बड़ा अच्छा जो है नजर आ जाता है सो वी कम्युनिकेटेड विद द फिजिशियन इसमें हमारे परफॉर्मा पर भी था और फिर उसको बाद में फॉलो अप भी जो है वो किया कि आइदर वो जो हमने रिजेक्ट किया वो पर्पस भी उसका हुआ फेल या नहीं और फिजिशियन भी सेटिस्फाई हुआ या नहीं इसमें थोड़ा सा कम्युनिकेशन बड़ी जरूरी है अभी मैं अपने इधर डॉक्टर को नहीं वो तो डॉक्टर साहब कहते हैं वो मेरे साथ लड़ पड़े जरा वो नहीं मैंने जो लिखा है बस आप वो करें मैंने कहा नहीं थोड़ा सा जो कम्युनिकेशन कम्युनिकेट करना जस्टिफाई आप करेंगे जाहिर किसी एक बंदे को जो उसने ओपिनियन बना लिया हुआ है डॉक्टर ने या उसके अटेंडेंट तो बेचारा मान जाता है लेकिन डॉक्टर को मनाना जो ना जरा मुश्किल होता है वो कई लोग मैं थोड़ा तो लेकिन उतना ही ये पर्पस जो है ना एमआरआई साल बेहतर करेगा मसलन फर्ज करें मेटाबॉलिक डिसऑर्डर जो है वो या फर्ज करें आप गैस्ट्रोएंटरोलॉजिस्ट हैं हम आपने बिलियरी पैसेजेस देखने हैं बिलियरी पैसेज एमआरसीपी मच बेटर देन द सीटी स्कैन तो कई लोग उनको एजुकेशन ही वो सीटी एडवाइस देते हैं तो हमने कहा नहीं आप एमआरसीपी जो है वो करवा अगर फॉलो अप करने आप अल्ट्रासाउंड एक पेशेंट ऐसा था जिसका उन्होंने ऑपरेट हुआ था और वो पस देख रही ठीक है अब वो जो पोस्ट पस उसकी सर बन गई उसको जो है ना वो अल्ट्रासाउंड बता देगा ये पस है अब पस को तो निकालना है ना सीटी करना तो नहीं है उसका हाल उसको निकालना हमने क्या किया कि हमने वो अल्ट्रासाउंड गाइडेड जो है निकाल दिया एस्पिरेट कर दी तो पर्पस पेशेंट का जो है ना वो भी पूरा हो गया और फिर जब ये कम्युनिकेशन उनके साथ होगी तो जाहिर जो रेफरेंट फिजिशियन है जो उसका प्रॉपरली प्राइमरी फिजिशियन है वो भी ये सेटिस्फाई करना हो और कुछ को हमने 4 को ऑप्टिमाइज भी किया है जैसे जो मल्टीपल का उन्होंने लिख दिया तो हमने कहा नहीं जी इसमें 2 आप करवा लें जिससे भी जो है मसला हल हो जाएगा या सिर्फ चेस्ट करवा लें इससे भी मसला जो है हल हो जाएगा सो जस्टिफिकेशन एक चीज है और ऑप्टिमाइजेशन जरूर
Thank you so much, Professor Dr. Iqbal Hussain Dugar Sahab, for this informative talk. Sir, do you want to say something?
Yes.
My name is Sharon. I'm doing this one over here. मेरी कह रहा हूँ कि जो आपने इमेज लो एज इसका कोई स्केल है कि कितना मिनिमाइज लेवल पे करना चाहिए लो
हाँ ये जरा रिस्क तो इसका जरूर वो लो कोई जब आपने आयोनिक रेडिएशन दे दी एक से भी जरूर उतना होने नहीं उसके जो कुछ साइड इफेक्ट्स है उसके लिए लेकिन जो म्यूटेशन के लिए ना उसके लिए कोई जो है ना मुश्किल नहीं उसके लिए ना अगर एक भी रेडिएशन से चले जो म्यूटेट कर देगी लेकिन उसके जो एक्यूट इफेक्ट्स होते हैं फर्ज करें जो ना बोलते हैं किसी से डायरिया हो जाता है या चेस्ट इन्फेक्शन हो जाती है या प्रॉब्लम उसमें फिर जो है डोज पे डिपेंडेंट जो होता है लेकिन इसीलिए कहते हैं कि इसको आपने अवॉइड ही जो है ना वो करना है और इसलिए जस्टिफिकेशन बहुत ही जो है ना वो सॉलिड होनी चाहिए नहीं है कि मतलब आप ऐसे जो ना सीटी स्कैन जो ना किसी को लिखते हैं और सीटी जो ना एक्सेस से और ज्यादा जो ना बोलते हैं रेडिएशन है 1 सीटी ब्रेन is equal to 100 chest x-rays.
Thank you so much, sir. Our next speaker is Mr. Muhammad Zishan. And the topic of his talk is a situation analysis about the availability of WHO recommended essential diagnostics tests for communicable diseases in public hospital laboratories of Karachi, Pakistan. So over to you, sir. And it is requested to all participants and speakers that please be brief. Yes, if you are comfortable there, we will.
So, thank you very much. I'm Dr. Mohammad Zishan, and my presentation is about the WHO in vitro essential diagnostic test list, glimpse of situation of communicable disease. So, I have nothing to disclose. These are outlines of my presentation. So, we know that SDGs, Sustainable Development Goals. The third one is the good health, and for that good health, one of the important indicators is the eradication of epidemics like malaria, tuberculosis, neglected tropical disease. This could not be achieved without a good diagnostic laboratory services, which is the core of this eradicate this situation. But the ground realities are also on the other end of the slide. Like if we see that the 3 to 5% of the healthcare spending we do on the diagnostic services, and the total R&D for diagnostic services we spend low middle income countries is less than 5%. If we see some realities other than this, the anti-malaria treatment in high-income countries have very low diagnostic facilities, and for that, yes, different mortalities and different outcomes. We see that in West African countries, these are the outcomes of due to these are high endemic areas but have very poor diagnostic services. Similarly, in TB, we are on the endemic area country, but we have diagnostic gaps. Like we are in the top 10 countries who have a diagnostic gaps in TB. Like we have 6.6% diagnostic gap. Similarly, for other diseases like neglected tropical diseases, they are the high income countries and low middle income countries. There are significant gaps in the diagnostic services. And for non-communicable disease, this is the Lancet publication which shows that there are high communicable gap to diagnose these conditions. These are the gaps, but they are the solution which has improved the diagnostic services and utilization of the diagnostic service across all the low middle income countries. For example,
I support if you can help.
please, excuse me.
Please.
So these are the challenges which was overcome by universal health coverages, global health security agendas, antimicrobial resistance. And 2018, WHO in vitro essential diagnostic test list was introduced. And last but not the least, the COVID diagnostic services. These are the things which has improved the diagnostic services across all the countries, especially developed. So this is the essential diagnostic list, which was introduced by the WHO in 2018. Basic agenda of this diagnostic list is to have two types of categories, like generic categories and disease specific. And the level of care it caters is the primary healthcare and healthcare with laboratories. This was a test list which was introduced in first, second, and third. It was gradually increased. Initially, it was 62 tests, which was recommended by WHO. Now it extended up to 175 test lists, which for all across all the healthcare facilities. These are includes different non-communicable, communicable disease, and in fact, technical pathologies as well. So to implement this, India has used this essential diagnostic test list for implementing a national essential diagnostic list. And this was a case study. India was the first country. So they had their national health missions, which was introduced in 2015, in which they have invested $175 billion for the free radiology, free medicine, and different diagnostic services. From those experiences, they have developed some certain guidelines, and using their disease control program and public health standards, they develop a national essential diagnostic list, which has now implemented across India in different parts of the states, and which they have used different pathologists, microbiologists, radiologists to introduce these tests. So these tests are available in all the healthcare facilities of India, primary and secondary and tertiary health. So my study objective was to determine the proportion of in vitro diagnostic tests for communicable disease, because we have a high communicable disease burden in our public health laboratories of Karachi, and this is the barrier encountered in showing the availability of these tests in our public hospital laboratories. So it was a mixed method study. We used the explanatory sequential mixed method design conducted in 2 month period, September and October 2022. We include 14 laboratories of the Sindh, of the Karachi, I'm sorry. 9 agreed to participate. Out of that, 4 were tertiary care. They are all public hospitals, and 5 were secondary hospitals. We examined 9 assays. These 9 assays were important in diagnosing of communicable diseases. These are the general tests like CBC and culture tests like this. And we specifically see the 39 assays for 13 specific diseases which are endemic in these parts of the world. And we did the qualitative assessment by in-depth interviews to see what are the barriers. Data was collected for the general test. It was like for microbiology, there are 4 tests, clinical chemistry 3, and similar hematology, clinical pathology 1. And these were the 13 diseases for which 39 assays it was recommended by WHO to evaluate. These were the diseases which are common in this part of the world. And we for sustainability of tests, we asked these 3 questions by the participants to see if their test was discontinued in the last 1 year, name of the test, and the reason for discontinuation. And we did the qualitative in-depth interviews. So these were the result. Karachi has 7 districts, and so you can see the largest district, which was like 2 districts do not have any public hospitals, like East and Kimari, they do not have any hospital. Maliri, which is the largest district, it has only public one hospital, and the 4 tertiary care hospital is the district south, which is the smallest. So the tertiary care hospital are mostly clustered in the one small district, and the other district do not have any hospital. This was one finding. Quantitative, we found that these 2 bars show the number of technical staff, red bar show the total number of pathologists, and these are this graph line shows the number of tests they have performed. So you can see that the technical staff was available at that time to perform these tests, but the number of pathologists, you can see there was negligible. Even the one pathologist available, and they were only doing the administrative job. Some hospitals do not have pathologists to report the results. Availability of general tests. Usually these tests were like, these are the name of the test, clinical microbiology. So the staining, which is an important part of the microbiology, which was done only in few hospitals, 6 hospitals out of 9, which was only tertiary. In secondary hospital, they are not doing any staining procedures like for any culture stainings. And the cultures, blood cultures, antimicrobial sensitivity was done only in 4 hospitals. No secondary hospital was doing any sensitivity and culture. And they have the sufficient number of tests, and there are sufficient number of supplies. For hematology, for chemistry, they are doing blood sugar in all hospitals. Whereas the CRP, which is an important test for infection, inflammation, it was done in only 5 hospitals at that time, and no co-calcium was done, which is an important mark for inflammation. Similarly, for hematology, CBC was performed in all the facilities, but CSF count and differential count, which is an important test in case of meningitis, was done only in 2 hospitals out of all these public. So there was no CSF count, emergency in the hospital. Similarly, for microscopy, it was done almost in all the hospitals. It was a dengue season and the most high endemic areas, but I see only the few hospitals has dengue antibody, dengue antigen, and only hospital has, one hospital also did not have antigen and antibodies at that time when I was doing survey. Screening test for HIV, Hep B, Hep C, which is available in almost every hospital. But the other test, which see the therapeutic outcome, which see the prognosis, it was not available in any hospital. Similarly, for malaria, the situation was comparatively better compared to other tests. Hepatitis B, C, PCR was only available in 3 hospitals, large tertiary. Even in tertiary hospital, they do not have hepatitis B and C reagents and supplies. So these were the tests on the extreme right. These were the tests which were available in different hospitals. And these were the tests which was absolutely, there was 29 assays which were recommended by WHO. It's not available in any of the facilities, secondary tertiary hospitals. So the large group of tests which was not available in any hospital. So and when I see the score of the availability of tertiary care hospital has, it's like 48% of the tests available, and for secondary care hospital it's 23% only tests available, which is recommended in WHO diagnostics. These were the tests which were discontinued, and mostly they were discontinued because of the non-availability of the case at that time or even across the year. For qualitative, what I found is that there was the pathologist which was designated there, they do not have a clinical degree, they do not have a clinical background. And only one or two, and even one laboratory was run by the BSc Technology as administrator, and they were doing the reporting for that. Problem identified after in-depth interviews that mainly equipment purchase problems, like they have fixed budgets, they have difficult procurement process, annual tender system, which they do not handle the situation, pandemic situation and critical situation. Human resources, they were not hiring for last 10 or 15 years. They were wrong deployment. Some were deployed in the technical staff deployment in pharmacy, some were deployed in dialysis and so like this. So they were not trained. Less training opportunities. They were not trained for centuries, like 30 years. They did not have any single CME session. The biomedical support service was not provided by health ministry, so they use their own resources to resolve the issues. So they have limited budget for this, and they do not have any data management system. They use their own laptops and Excel sheets to store the data. And the clinical and the lab do not have any liaison, so they do not have a perception that lab make or and what happening in clinic. So whatever report they are generating, they accept or whatever problem they do not communicate with them. So I suggest from this policy that so it's my last slide, second last. So that we should have a uniform test menu from different hospitals, like from secondary have a uniform, for tertiary have some uniform like culture and sensitivity should be done in all the secondary hospitals to reduce the load of tertiary care hospitals. Similarly, malaria, bloodborne, STIs, influenza, these should be done in secondary care hospitals, so we can handle the patient in secondary care hospitals. There should be a rapid diagnostic test available. And for complex tests like NAN and immunoassays, those activities, they should be referred to tertiary hospital rather than doing secondary, because it's a complex test. There should be a referral system between secondary and tertiary, which was absolutely not present there. And budget should be flexible for laboratory diagnostic services. We should have a public-private partnership, which was there, and there was a good outcome in that situation. And there should be dedicated budget for equipment, accessories, books, and manuals. And last but not the least is so there should be a procurement committee. The procurement committee is only run by the lab administrator, do not involve lab administrators. So whatever they give, the higher management give to lab, just rely on that. So there is no input from the lab to the procurement committee. And there should be a pool procurement mechanism. In Africa, there is a pool procurement mechanism. Like for secondary care hospital, there is a pool mechanism. So if one secondary care hospital has something shortage, they can ask for this other one. There should be a pool procurement mechanism. There's a need for hiring and education according to different educational criteria. There's a need for clinical microbiologists in all the hospitals. There's no microbiologist at that time, even now. And there should be an annual training program for all the technicians and doctors, and that should be linked to the annual contribution reports. And there should be a good support system, whereas a LIS system or any biomedical system should be a very dedicated budget for all these things for each president. So my conclusion is that there's a disproportionate pathology technical ratio in tertiary and secondary care hospitals. General tests for chemical, hematology, and clinical pathology were not available according to the list. Culture and sensitivity was not available in tertiary care hospital even. Only screening tests for Hep B, Hep C, and HIV, and no other tests were available for other tests. Similarly, sexually transmitted infection, pharyngitis, aspergillosis, human papilloma, these tests were absolutely not available. We are seeing the number of cases of these patients are increasing in Pakistan. So we do not have anything available right now.
Thank you so much, Mr. Muhammad Khan, as we are short of time. Okay, okay.
That these hospitals should undertake this as per recommendation. So not available in problem there because they do not follow this. This is what just around that. So they do not have any national level at a list that we want. So it depends upon the it depends upon the hospitals. So they only those things which is more academic. So they are not following measures. We do not have any national policy for any kind.
And probably we do not have a budget for that. We do not have pathology they do not have any pathology department proper who identify that there should be a pandemic, there should be some problem. There's a monsoon season, so we should have a better procurement supply chain management system. So there are disconnection between different departments. So the procurement done by some other person, like higher management, they do not ask the lab person that what's your need. So there's so many things between there's lack of gap.
Yes, sir.
सर मतलब कि इसमें मेरा मेरा ख्याल है उसके लिए कि अगर हम जो टर्शियरी केयर और जो टेस्ट हो रहे हैं फॉर एग्जांपल कल्चर एंड सेंसिटिविटी टेस्ट हो रहे हैं अगर हम उसको नीचे ले आएंगे सेकेंडरी केयर में उनका लोड वहां से थोड़ा कम हो जाएगा कम हो जाएगा जो कॉम्प्लेक्स टेस्ट है जिसके लिए आपको कॉम्प्लेक्स टेक्निकल स्टाफ की जरूरत है कॉम्प्लेक्स मशीनरी की जरूरत है कॉम्प्लेक्स रिएजेंट की जरूरत है सो अगर सेकेंडरी केयर में उस तरह से हम शायद हाँ उसके थोड़ा मुश्किल होगा हमारे जैसे नहीं होगा हम अगर उसको सेकेंडरी केयर को में कॉम्प्लेक्स इट्स अ वेरी कॉम्प्लेक्स वेरी एक्सपेंसिव टेस्ट सो अगर हमें उसको उसकी मॉनिटरिंग के लिए पैथोलॉजिस्ट चाहिए और बहुत सारी और चीजें चाहिए तो अगर हम उसको टर्शियरी केयर में रखें ज्यादा एंड सेकेंडरी में उससे थोड़ा सा हमें रिशफल करना पड़ेगा यस
Thank you so much, sir. So our next participant is Ms. Sidra Ishfaq, bridging the gap, women's empowerment as a pathway to reducing out-of-pocket health expenditure, catastrophic health expenditure and improvement in Pakistan. So over to you, Ms. Sidra, and it is requested that please be brief. Okay.
Assalamu alaikum everyone. It's me, Dr. Sidra Ishfaq, and I'm serving as a senior research officer and assistant professor here in HSC. And today I'm going to present on the topic of bridging the gap, women's empowerment as a pathway to reducing out-of-pocket health expenditures, catastrophic health expenditures, and impoverishment in Pakistan. The table of content that I will start with introduction. As we all know that out-of-pocket health expenditures are those payments that households are made at the time, directly paid at the time of receiving the healthcare services. And these payments becomes catastrophic when they are becoming equal to or exceed 40% of the total financial burden of households, financial capacity of the households to cover these costs. And we also know that in low and middle income countries, healthcare services are mainly financed through out-of-pocket health payments. Despite significant improvement in achieving the universal health coverage, especially the healthcare services in low and middle income countries are still lagging behind, and they're inaccessible and inequitable because of the high burden of out-of-pocket health expenditures. Globally, it is estimated that there are about 200 million people who are facing and incurring the catastrophic health expenditures around the world, and there are about 100 million people who are pushing towards the poverty line because of these health expenditures. So these payments are considered inefficient, inequitable, and least sustainable way of financing the healthcare services. Therefore, the heavy reliance on out-of-pocket payments, specifically in wealthy countries where the poverty and diseases are already widely spread, it increases the financial burden of households on receiving these services. So this is a graph that is showing the current health expenditures in Pakistan in comparison with the South Asian countries. And it is a data that is taken from the World Bank, and it is showing that in Pakistan, the current health expenditures are increasing day by day.
Ms. Sidra, please, it is requested to move to methodology and result section.
Okay, I just want to show these graphs also. So this is the which is the household expenditures on head, and which is the share of population that is spending more than 25% of the total income on health. And we can see that Pakistan is yellow and orange line, about 1.2% of the population and more than 25%. You can see that out of the total expenditures, about 53% of the expenditures are paying out of pocket payments. And this is the prevalence of impoverishment. Impoverishment means the risk of falling into the poverty line because of facing these catastrophic health expenditures. And we can see that About 31.4% of the population is at risk in Pakistan, who can be fall into the poverty if payments are made for surgical care and any kind of expensive healthcare services. So there are different reasons, mainly due to the lack of equitable and efficient health financing system, social protection, and health insurance coverage. A large proportion of the household's budget is spent on sick health utilization. Therefore, in order to meet their needs, households adopt and go for the coping strategies, like they withdraw their children from the schools and they use that money in order to fulfill their basic healthcare needs. And there are some other situations in which, despite the availability of healthcare utilization, some people are not availing that type of services because of some reason, and which will further worsen the healthcare status of the individuals, and it reduces the productivity and their income. And then this vicious cycle of poverty continues, and people become more poorer, and some other falls into the provisional level. It is also seen that in high-income countries, catastrophic health expenditures exist, but the high incidence of catastrophic health expenditures and impoverishment was faced only in the low-middle-income countries. A survey was carried out in 133 countries, which shows that about 800 million individuals are experiencing catastrophic health expenditures, and about 122 million are driven into the poverty as a result of these expenditures. So now, why women empowerment is important to study? Because women in Pakistan, especially in the rural areas, are deprived from their legal rights and they belong to the unprivileged group, and they find it opportunities to grow like the male counterpart. And the Pakistan is also lagging behind in gender. So women empowerment utilization and empowerment reinforces the decision making of women at the household level, which further leads towards the improved access towards the financial resources and healthcare services. And it is evident from literature that empowered women can make better decisions in terms of their child health and education, household and food nutrition security, and to elevate the rural poverty. And women are also experiencing about 43% of their agricultural labor force, both globally and in the developing countries, and are producing about 50% of the world food. Therefore, it is very important to incorporate the women's role in determining these kinds of health expenditures. According to the Gender Inequality Index, Pakistan is ranked at 136 out of 162 countries, and according to Gender Gap Index, Pakistan is ranked at 151 out of 153 countries. This shows that there is extreme gender inequalities prevailing in Pakistan. Therefore, it is important to study this topic. So this is a graph that is showing the prevalence of gender equality. And here we can see that in Pakistan, gender equality is about only 20%, which is very low as compared with the other parts of the country. So the research gap, there are different factors were identified in literature, which can be used in measuring the access and utilization of healthcare services, but women empowerment got least significance in this scenario. And then there are different policies were devised and implemented, but in improving the accessibility and coverage of health services. But women's role is missing in all these policies. So the relationship between women's empowerment and healthcare used to be under research area, especially in Pakistan, where there is high mortality ratio and gender disparities are existing. So the objective is first of all to estimate all these kinds of expenditures and to develop the relationship and check the impact of women's empowerment in reducing these out-of-pocket expenditures, household catastrophic health expenditures, and then impoverishment in Pakistan. So these are the contributions. First of all, the previous studies used only 1,000 variables to define women empowerment. So I used the multi-dimensional women empowerment index to define women empowerment in context of Pakistan. Then I used to develop a relationship between women empowerment and all these types of indicators, which was not done before. And then there is one more contribution on the methodological side by using the multi-level mixed effect logistic regression modeling at different levels, that is households and communities. Research methodology that is from the highest, that is how economic survey, which was published by Pakistan Bureau of Statistics and to competitive and professional households, urban and rural areas. There are different types of health expenditures were recorded in this survey, like expenses on medical products, appliances, equipments, outpatient and inpatient services. And then I used individual and household level characteristics in my regression analysis. Women empowerment was calculated by using the 9 domains of decision making, and then use the principal compton analysis to develop the index. And then WHO's per adult indicator scale was used to determine the impoverishment level. And multi-level mixed threat logistic regression is used in both models to check the impact of women empowerment. So these are the study areas that is almost whole Pakistan is included in that survey. Results and discussion. So these are the results from the factor analysis. Here we can see that the decision making in 9 domains were used in developing the index. And then these 3 categories were devised by this index, which is low empowerment, medium, and high empowerment. And it is used as a key independent variable in the regression analysis. So for the sake of dependent variables, we are using here the catastrophic health expenditures. And here we are using a 10% threshold level to define the catastrophic health expenditures. When out-of-pocket payments were exceeding more than 10%, then we considered that these payments are catastrophic health payments. And then by using the threshold level, we develop the dummy variable. If the value is more than 10%, we find it is equal to 1, other value is equal to 0. And then the second dependent variable is the proportionate effect. Here we can measure here the poverty head counts, and then it is compared with the poverty line of Pakistan, which was measured by Ministry of Finance, and it is about rupees 3,776. It is compared with that, and if the households are incurring more than this amount, it is equal to 1, otherwise it is equal to 0. And then these are the results from statistical analysis, and we have found that women empowerment remains a significant factor in lowering all these kinds of expenditures: out of pocket, catastrophic, and impoverishment. By 1 unit increase in low empowerment, medium, and high, out of pocket health expenditures were reduced by 1.8%, 2.11%, and 1.58% respectively. And it is found that even if the women had low empowerment in decision-making domain at the household level, the out-of-pocket health expenditures can be lowered. Similarly, by using the threshold level 10%, the women empowerment can be helpful in reducing catastrophic. By 1 unit increase in women empowerment, impoverishment level can be reduced by 80%. So this is the table results from multi-level mixed effect. Here we are using the 3 types of dependent variables, that is out of pocket, catastrophic, and impoverishment effects. And here we can see that these 3 categories of women empowerment, which is showing that negative and significant impact with the dependent variables. It means that at 1 unit increase in women empowerment, the dependent variables are reduced by that respective units. Moreover, we can also here see that variance partition coefficient is significant, and it is showing that some kind of variation is also exerting by communities on the dependent variables. So communities are also playing their pivotal role in defining these expenditures. So conclusion, out-of-pocket health expenditures, we have seen that they are exerting pressure on household capacity to pay and push them into the poverty. And we have also found that women empowerment is a significant factor in reducing these type of health expenditures. So policies and programs should be aimed at all women, by devising the policies by considering all women with more focus on those women who have their lower education and who are belonging to the lower contacts. So the existing policies which are implemented today tax the women's role. Women's role is missing in all these policies. Women are not involved in decision making. Policies are not made on international grounds. There is no gender marker or checklist at Pakistan level which can be comparable to the other parts of the world. And then there are governance issues in devising these policies. Moreover, there is a lack of sustainability and consent of all stakeholders when devising the policies. They are made in silos without the consent of all other stakeholders. So what should be done? There is one simple idea that bringing together all sectors and policymakers from all venues. So the policies made by these bringing together the sectors and policymakers will be more effective, focused, and will be sustainable in the long run. And the goal is to incorporate the women's role while developing the policies, and women's efforts should be documented on international grounds. Thank you.
Okay, thank you so much. So moving next towards the next participant, Dr. Mohammad Suhail. Dr. Suhail Akhtar will present prevalence of non-alcoholic fatty liver disease in Pakistan, a systematic and meta-analysis. Dr. Kausar. Dr. Kausar? Okay. Dr. Suhail. Okay, जी Dr. Joseph, please present.
आज का जो मेरा टॉपिक है मेटा एनालिसिस जी नहीं ठीक है हमारा जो टॉपिक है मेटा एनालिसिस है नॉन फैटी लीवर
आप माइक जरा करीब करके काइंडली चेक कर लो।
जी अब आवाज आ रही है नहीं आप मैं पकड़
You can change the seat.
ओके चलिए ठीक है अच्छा आज का जो हमारा टॉपिक है
Miss Sidra, very still.
जी बिस्मिल्लाहिर्रहमानिर्रहीम आज का जो मेरा टॉपिक है वो नॉन फैटी लिवर डिजीज पे मैंने मेटा एनालिसिस किया हुआ है और इसके हमारे जो टेबल कंटेंट है वो इंट्रोडक्शन है, प्रेवलेंस है, ऑब्जेक्टिव है, इसके रिजल्ट्स, कंक्लूजन्स और इसकी ग्लोबल प्रेवलेंस हमने देखी है, ये नीड क्यों थी हमें मेटा एनालिसिस करने की और इसके मटेरियल एंड मेथड्स आ रहे हैं, इसके कंक्लूजन्स। तो फैटी liver disease is characterized by the accumulation of excess fat in the liver leading to potential liver damage. It progresses through stage including steatohepatitis, fibrosis, and ultimately liver cirrhosis. Alcohol fatty liver disease and non-alcoholic fatty liver disease are the two main types. And non-alcoholic fatty liver disease जो है उसकी टू स्टेजेस होती हैं, नॉन अल्कोहलिक फैटी लिवर एंड नॉन अल्कोहलिक स्टीएटोहेपेटाइटिस जिसमें सिर्फ इन्फ्लेमेशन होती है। There is no such research in Pakistan that can explain non-alcoholic fatty liver disease, pooled prevalence and related risk factors of non-alcoholic fatty liver disease. Global prevalence of non-alcoholic fatty liver disease is estimated to be 25, with Europe and North America 23.7 and 24.13, and Asia at 27.37. In Asia, the overall prevalence of non-alcoholic fatty liver disease is reported to be 29.6, with South Korea at 32.8, China at 29%, and Japan at 22%. Prevalence of non-alcoholic fatty liver disease in Pakistan. Pakistan has experienced a notable increase in prevalence of non-alcoholic fatty liver disease attributed to lifestyle changes, dietary habits, and rising obesity and metabolic disorders. Studies conducted in different regions of Pakistan indicate a wide variation in non-alcoholic fatty liver disease prevalence ranging from 13.77 to 77.5. These variations highlighted the need for comprehensive analysis and targeted intervention in the specific region. A need क्यों थी स्टडी का the non-alcoholic fatty liver disease a significant public health concern around the world, particularly in the developing countries such as Pakistan. As a developing country, the prevalence is rapidly rising in the Pakistan. There is no such research in Pakistan that can explain non-alcoholic fatty liver disease pooled prevalence. Because of that, I did meta-analysis and relevant your related risk factors of non-alcoholic fatty liver. As a result, a meta-analysis of existing non-alcoholic fatty liver disease studies in Pakistan can provide important information about the disease pool prevalence and guide future disease research. Objective क्या थे? The primary goal of this research is to determine the pool prevalence of non-alcoholic fatty liver disease in Pakistan, to determine the pool prevalence and to determine the pool prevalence in general population. तीन हमारे थे गोल in general population. पहले in Pakistan में हमने prevalence देखी, फिर general population, फिर then in individual with metabolic disorders के साथ. Research design हमारा meta-analysis is a method to use to bring together information from many different studies on a particular topic. It is like taking the results of several smaller studies and combining them to create a bigger and more reliable picture. By doing this, research can find common pattern, identify trend, and get a more precise understanding of the overall finding. It's a powerful tool that helps us to make a well-informed decisions and draw more dependable and conclusions based on a large body of evidence. A research strategy and data source. Thorough research strategy was employed utilizing database like Midline, Web of Science, Google Scholar, and local database. Keyword and mesh terms were combined to target relevant literature. And the research was limited to English article published from January 2000 to March 2023. Inclusion criteria, this study included articles that provide essential data on the study population, diagnostic process, and prevalence of non-alcoholic fatty liver disease in different locations around Pakistan. Exclusion criteria that this study excluded articles that used to unclear prevalence of non-alcoholic fatty liver disease, had an unknown sample size, or had case control studies. Quality assessment the Jonah Breeze Institute checklist used for the prevalence studies was used to evaluate the quality of included studies. 9 criteria, including sample frame, sample size, and data analysis, are included in the Jonah Breeze Institute checklist for assessing prevalence studies. The statistical analysis हमने जो choose की हमने studies उनके ऊपर जो लगाया, the statistical analysis for this meta analysis of the prevalence non-alcoholic fatty liver Pakistan involves several steps. The analysis was conducting using the R statistical software version 4.2, and heterogeneity in the meta-analysis refers to the variation or diversity of the study result across different studies included in the analysis are the due to differences in the study characteristic or study methods. Random effect model, we use random effect model because random effect model provide an estimate of the overall effect by considering variations within individual study and differences among studies and ensuring that no single population dominate the overall estimate. Fixed effect model था जो कि हमने नहीं use किया. Fixed effect model हमें क्या देता? The model assume that all studies in the meta-analysis share the same underlying effect size, which may not hold true for proportions due to the inherent heterogeneity. Proportions can vary widely across studies, and using fixed effect models may lead to an oversimplified and inaccurate representation of the true effect. Sensitivity of analysis, sensitivity of analysis is the method used to examine the robustness of the results by systematically testing the impact of and excluding or modifying specific studies or parameters to assess the influence on the overall findings. Publication bias is defined as the failure to publish the result of a study on the basis of the direction of or strength of the study findings. दो टेस्ट इसके अंदर हम यूज करते हैं.
I want to interrupt Dr. Kosik. Please move towards briefly towards the results and conclusions.
Okay, results, selection and statistic हमारा क्या था? Out of 74 articles initially considered, 29 studies were chosen for the meta-analysis after a careful selection process that involved removing duplicates, excluding unrelated entries, and reviewing full text articles. The study analyzed 7,869 participants from various studies. The sample size ranged from 87 to 1,366 with a median of 210. The average age of non-alcoholic fatty liver disease patients in the study was between 27 and 55. Male participants accounted for 480 out of 1,590 में से 480 males थे और 535 में से हमारी जो है 535 out of 1,698 जो females थी उनमें से 535 जो हमारी females थी, including and the included studies had different designs with 29 being cross-sectionals and I being prospective. The included studies were evaluated methodologically. 18 were rated moderately biased and 2 were placed low. हम फ्लो चार्ट से मैं इसको दिखाना चाहूंगी कि हमने जो टोटल हमने स्टडीज टोटल जो हमने आर्टिकल्स लिए थे 745, लेकिन 337 डुप्लीकेट थी, इसलिए हमने उनको निकाल दिया। उसके बाद हमारे पास 408 रह जाता है। उसमें से जब हमने उनको उनके टाइटल और उनके हमने देखा उनका अब्स्ट्रैक्ट और टाइटल को पढ़ने के बाद 334 जो है वो एक्सक्लूड कर दिए गए क्योंकि रेलिवेंट नहीं थे। और फिर उसमें से हमारे पास जो पीछे बचे 74, उनमें से हमने जब उनको थॉरली स्टडी किया तो हमारे पास जो है वो रिपोर्ट हमने एलिजिबल की, लेकिन उसमें से रिपोर्ट जो है डुप्लीकेट, उनमें से फिर दोबारा 10 हमारे डुप्लीकेट थे। रिव्यू आर्टिकल 19 थे और नो डाटा अवेलेबल जिनका हमें मिला वो 11 आर्टिकल थे। इररिलेवेंट हमारे पास 5 आर्टिकल थे।
मेरे
तो
प्लीज
स्टडी
कंक्लूजन की तरफ
रिव्यू
आ जाए।
29 और ये हमने टोटल जो स्टडीज की हैं। इसके बाद हमारी 2 जो फॉरेस्ट प्लॉट और फनल जो है वो हमें बताती है कि हमने कोई बाई स्टडी नहीं यूज किया था। हमारा जो रैंडम इफेक्ट मॉडल जो है जो हमने यूज किया, प्रिडिक्शन है कि 7,916 पॉपुलेशन में से जो जनरल हेल्दी पॉपुलेशन में से 29 जो है उसमें नॉन अल्कोहलिक फैटी लिवर डिजीज आया। और फनल प्लॉट इसको बताता है कि कोई बाय स्टडी हमने नहीं की। और जो हमारा मॉडल था जिसमें डिजीजेस थी, डायबिटीज पेशेंट पाकिस्तान में वो 4006 थे और 58 जो थे वो हमें प्रेवलेंस में की
मैडम
मिली।
प्लीज कंक्लूजन के 2 पॉइंट्स चाहिए।
हमारे कंक्लूजन पे चले डिस्कशन। और हमारा ये था कि इन टोटल 74 स्टडीज वर रिव्यूड एंड 29 वर इंक्लूडेड। द पूल्ड non-alcoholic fatty liver disease prevalence in the general population was 29 और उसकी प्रिडिक्टिव जो हमारी वैल्यूज आई हैं, इंटरवल जो है वो अगर आप वो केयर करते हैं तो वो 2 पे भी जा सकते हैं। अगर केयर नहीं करते हैं और अपना लाइफस्टाइल चेंज नहीं करते हैं तो उनकी प्रेवलेंस 70 तक भी जा सकती है बेस्ड ऑन द 12 स्टडीज से जो हमें रिजल्ट मिला। इन द इंडिविजुअल्स विद मेटाबॉलिक डिसऑर्डर प्रेवलेंस जो है इन with diabetes, obesity and hypertension was 58 और प्रिडिक्शन इंटरवल था उनका 36 to 79 तक। और इसी तरह से ओबेसिटी में 74 था और हाइपरटेंशन में उसका 47.4 था। There was no evidence of publication bias, although a statistical significant level of heterogeneity was seen among the studies जो है। और हमारा future recommendation क्या थी? With the high prevalence of non-alcoholic fatty liver disease throughout the country, there is a growing need to conduct future research on this disease, particularly with regard to family debt. Thank you.
Thank you so much, ma'am. And I apologize for interruption. And it is requested to all the participants that just briefly go to your introduction slide, then objectives, 1 slide methodology, and 1 slide of your result and conclusion, because we are very short of time and we still have 4 participants left. Please, Dr. Sadia Saeed, over to you, and the topic of the presentation is assessment of knowledge and diagnostic capability of childhood autism among postgraduate residents in tertiary care hospital of Twin Cities. Please follow the instructions. Thank you.
जी आसान
As Dr. Sanjeev mentioned, the topic of presentation is basically assessment of knowledge and diagnostic capability of childhood autism among postgraduate residents. So basically, childhood autism defined by American Psychiatric Association as a spectrum. मुझे माइक से मैं बहुत ज़्यादा comfortable है इसमें. The American Psychiatric Association basically defined autism spectrum disorder as a spectrum of neurodevelopmental disorder, occurring early in childhood, characterized with persistent ability, social communication, intellectual and receptive and ability spectrum of behavioral activity. So this is basically as a significant burden of the issue and ability to return and fail to control. Okay, in Pakistan, basically, Pakistan is the fifth most populous country in the world and country in South Asia with more than over 197 million people. So in Pakistan, we believe that 345 out of 600% have autism spectrum disorder. In Pakistan, unfortunately, autism spectrum disorder was diagnosed by multiple psychologists, pediatricians, psychiatrists, or psychiatrists. These there are some religious beliefs that they are getting treatment from some religious scholars. But unfortunately, there are no standardized tools available in Pakistan to diagnose autism spectrum disorder.
Please go to objective slides.
As I mentioned before, there is no standardized screening tool, so Pakistan has no epidemiological data available in autism. In a study conducted in Karachi, they reported that half of the Muslims have never heard of the word autism. That's really the dilemma in Pakistan. So this is basically the need for the study to conduct study on post-study residents. They are the future members of the multidisciplinary to diagnose and reach autism challenge. So we in both globally and locally, there were no research conducted on autism spectrum disorder specifically among healthcare professionals because they are the main member in which parents and other care providers approaches and diagnosis. The objective is basically, as I mentioned, this is the knowledge and this is the diagnosis of the diagnosis. So aim is basically to decrease the burden of autism through timely and right decisions by health authorities. The significance of this study basically lies in its potential to enhance the healthcare benefits by closing the knowledge gap and also identify the gaps to cooperate in future medical supply and professional continuous control programs. So, coming to methodology is basically a descriptive professional study and study settings are been and related to hospitals. And it's basically a 3-month during study. Sampling technique is simple random sampling. Okay, based on the hospital medical record, there were 595 postgraduate residents registered in James and PA. So I basically calculate data about 87 and regarding inclusion and exclusion criteria, basically inclusion all postgraduate residents who are working as a postgraduate resident at a secure hospital, and regarding exclusion criteria, postgraduate residents who are on annual leave in the study period and also who had been worked as a multi-disciplinary working areas. So all basically the participation of postgraduate residents were voluntary and comprehensive and also the ethical pluralism from agency and as well as the ethical board of BGA and this. So the tool I will use in that questionnaire basically is a knowledge of some healthcare worker questionnaire at the psychology and psychiatry in Nigeria and then it was modified in 2020 by Australian psychologists and psychiatrists. So that tool has received 4 domains for interaction. Second domain is about impairment in communication, and third domain is about regulating a restrictive pattern of behavior as observed in child autism. And fourth domain is about type of autism disorder and related comorbidities. That is basically a diagnostic portion for. Basically, data analysis that I do is basically chi-square to determine the association between converter variables. Okay, coming towards results, basically from Pim's hospitals, 58% postgraduate residents were participated, and from DBS 74%, and from Holy hospitals and I included Holy hospital because in DBS the unit of neurology participated was 49. So that's why I wrote Holy. Okay, Okay, so in regarding results, the quite alarming situation that no 0% post-graduate formal training of autism, and just 13% have previous encounter with autism, and only 1.7% have previous participation in the evaluation and management of child autism. So that basically current period. And regarding question, basically out of 287 post-graduate residents, just 35% post-graduate residents had good knowledge of child autism, and 6% had poor knowledge.
Please move towards conclusion.
People in this basically and this full significant orgasm on post-graduate resident body, childhood autism, the findings highlighted agency, period, intervention, and curricular enhancement for a more informed and useful algorithms. So, information basically established comprehensive autism training programs to build healthy professionals with in-depth knowledge and practical skills, and also collaborated education institutions and guidance. And sir, positive point is that in the agency, we basically started autism training, regarding integrated behavior and rehabilitation certification. So we included basically 15 participants included in that certification, and we started that after that research. Thank you. The knowledge, it will be question that it says state knowledge of our realization ability of us. So basically that is knowledge के साथ आप diagnose के ऊपर बात पूछता knowledge है या either वो दूसरे तरह के diagnose कर सकते हैं नहीं क्योंकि उस तरह की तरीके से ऐसे mental की वहाँ हम different आपके सामने different कर रहे हैं psychological कर रहे हैं psychiatrist.
Thank you so much, Dr. Sadia.
Just go the slide of the background where I as 300 out of the 600 people, 300 people are okay. So it's quite responded. Half of our population is autistic. So I was trying to find out the reference of this item.
Okay, that reference, I also provided the reference that basically studies that recently in India in one minute. And they basically
Please आप check कर लीजिएगा कि stats भी again stats again check कर लें क्योंकि हो सकता है कोई mistake हो आपसे ठीक है thank you so our next speaker is Dr. Atika Rahman, and the topic of her talk is outbreak of measles in Union Council located in the Sawabi district of KP. So over to you, Dr. Atika Rahman, and again a request, please follow the instructions.
My name is Dr. Atika Rahman, and I am FPPP 15 Cohort Fellow from DGHS KP. Thank you for joining me today as we delve into an important public health matter, outbreak investigation of measles in Union Council Kunda, District Sawabi, Khyber Pakhtunkhwa, August 2023. Next, please. So a little bit introduction. Measles is a highly contagious, serious airborne disease caused by a virus that can lead to severe complications and death. Measles vaccination, as it's a vaccine preventable disease, so measles vaccination deaths being between 2000 and 2021. Even though a safe and cost-effective vaccine is available, in 2021 there were an estimated 128,000 measles deaths globally, mostly among unvaccinated or under-vaccinated children. While in 2022, about 83% of world's children received one dose of measles vaccine by their first birthday through routine health services. Situation in KPK and Khyber Pakhtunkhwa, situation in Pakistan and Khyber Pakhtunkhwa. In 2021, a total of 10,399 cases of measles were reported in Pakistan and around 3,000 deaths were reported in 2020. In year 2022, around 4,000 cases of measles were reported from KPK province of Pakistan. In 2023, around 11,000 cases and 38 deaths were reported from KPK.
Dr. Atika, we want to see your objectives, please.
Sure. The objectives of my investigations were to assess the magnitude of outbreak, identify risk factors, and recommend control measures for prevention and control in future.
Please move towards my conclusion because we are very short of time.
Methodology, my study design was simple descriptive study. Study settings were areas in affected UC of district Sawabi. A working case definition was developed, and that was any resident of UC Kunda district Sawabi with onset of symptoms from 22nd May to August 26, 2023, exhibiting a generalized maculopapular rash lasting 3 or more days with a temperature exceeding 38.3 degrees centigrade and presenting with cough, coryza, or conjunctivitis. The data collection tool used was measles case reporting forms. Data collection was through review of BHU records, active case finding through house-to-house survey in affected villages of the UC. The results were that total 4 villages were affected in Union Council Kunda. Total cases were 26. Mean age was 43 months, ranging from 8 months till 120 months. Most affected age group was 25 to 36 months, and male to female ratio was 16:10. That is 62% males and 38% females. This was the epicurve of the cases starting from June, and the last case was reported on August 21, 2023. Next. These were the different villages of Union Council Kunda, Shagaicham, Jhangire, Kunda Mera, and Batlasu. Kunda Mera showed the highest highest number of cases. These were 15 in number. The vaccination status of cases showed that out of 26, 5 were vaccinated, 19 were unvaccinated, and 2 kids were not eligible, that is below the age of vaccination, they were 8 months. Age-specific attack rates were calculated, and that showed that the highest number of attack rates was among the age 0 to 4 years, that was 4 per 1,000 population. Next. Outcome of 30 household cluster. A total of 108 children were included in this 30 household cluster. 97 were eligible for MR1, out of which only 46 were vaccinated, while 71 were eligible for MR2 and only 29 were vaccinated. So the conclusion was the outbreak was largely attributed to a low immunization status among children in Union Council Kunda. This is evident from the vaccination data with a significant proportion of children being defaulted or ineligible. The lack of community knowledge about measles vaccination further compounded the issue. Actually, the prolonged strike of lady health workers in the district for the past 7 months has hindered community facilitation for vaccination, contributing to the outbreak's intensity. Lastly, recommendations. Health education of the community about BPD's vaccine preventable diseases and routine immunization must be ensured. Capacity building of PPI technicians. Outreach sessions should be regularly planned and ensured. All mop-up activities and outreach sessions must be monitored. Retrieval of LHW's activities and their role in health education should be ensured.
Thank you so much, Dr. Anika. So our next presenter is Mr. Salahuddin Khan, and the topic is GIS-based mapping and analysis of dengue mosquito breeding sites in district Swat KP. So, Mr. Salahuddin Khan, you have just 7 minutes. Please plan accordingly. Thank you.
making an analysis of the mosquito breeding site in this reservoir as a problem. Okay, next. This is my outline of presentation. Next. Dengue is one infection of dengue virus. This is transmitted to human by of infected human mosquito. They either 4 types of virus, dengue 1, 2, 3, and 4. And the infection in one serotype cause lifelong immunity against this serotype. And the dengue virus is transmitted by Aedes mosquito. There are 2 types of mosquito. Aedes aegypti is primary death, and Aedes albopictus is secondary death. Aedes aegypti is pre-rural urban area, domestic or domestic environment, while Aedes albopictus are found in rural area out at the home wild environment.
Please move towards the objective slide, please.
These are some data. Please go ahead. These theoretical framework of the object, these are the some biological factors, the ecological factor and demographics, which are responsible for causing outbreaks in any area, whether water area, this study that was a cross-sectional descriptive study that was keeping study and because it is a work based on the 2013 outbreaks. The study technique was a systematic rating survey. Duration of study was 6 months, and random survey 2 different survey tools were used for collection of large data analysis was done through SPSS and GIS mapping. The random insights quality data providing through GPS was incorporated to the health mapper and ArcGIS software through KML file. The paper map was taken from the Google Earth. Next. Clinical consideration was taken continuously of the data was kept larval indices. The most important thing in this research was the different type of larval indices. The house index, dental index, blood index, and pupil index. Actually, these are the presence of larvae in houses or containers or pupil presence in different areas. A total 900 houses were inspected for dengue larvae breeding. That 735 containers were surveyed in these houses. Among these 730 containers, 500 containers were found positive. In which 150 were plastic water tanks, 90 were cement water tanks, and so on. These are the geographical map and GIS maps where the study was conducted. These are the number of different containers which were inspected and found positive for larva or either pupa. These are the percentage of containers which are checked: 8% fountain, 10% jar, 25% plastic water tanks, 16%, and so on. These are entomological indices at the study sites. The house index was highest for 78, 80% was in Sibu Sharif and 77 was in Kolkata. Is container index, bed index, and K index, and both study sites given. This inspected container versus positive container versus positivity in this container. Plastic container in both study area with the percentage 81%. Similarly, 70 tanks commodes in for basin, tiles, fountain, and jar. Lava positive container versus pupa positive container. So these are the containers where we found in some lava and in some pupa 80% is given and number of.
Please conclude your talk.
This conclusion. The study area was selected on the basis of past dengue outbreaks in 2013. The larval surveillance was carried out in peak season of dengue in urban and semi-urban areas. The data analysis was carried out through SPSS and ArcGIS was used for breeding site data visualization. And the ArcGIS is used to map the breeding sites of dengue vector and vector density in the study area. Result to reveal that plastic tanks, tiles, and cement tanks were the most preferable or potential breeding sites for dengue vector. Is that recommendation? Prevention installation of rainwater in a hard soil waste management practices at community level. This is recommended. Keeping tiles, box, coolers, and basins under the roof so that no water, rainwater may be collected. To prevent dengue outbreaks, IVF strategy needs to be adopted and implemented in the study area and also in other high risk areas of compliance. Multi-sectoral approach, social mobilization, and community engagement with behavior change at all levels are key to control and prevent dengue outbreaks in future. Thank you.
Thank you so much, Mr. Salahuddin. Do we have our next participant, Dr. Noshin Naz?
Yeah.
Okay, Dr. Noshin Naz will be our last speaker. Empowering communities, increasing family planning uptake through community mobilization, demand generation, and accessible services in peri-urban communities in Karachi, Pakistan. So over to you, Dr. Noshin.
Yes, thank you so much, Dr. Sabine. I am presenting the aspect of empowering community, increasing family planning uptake through the community mobilization, demand generation, and accessible services in peri-urban areas of Karachi. Next. So I am presenting this from Water Pakistan Trust, which is the non-profit organization, and the aim is to provide quality healthcare services for women and children in peri-urban areas of Karachi. Next. So background of my abstract of study was Pakistan is the fifth most populous country of the world, and we are facing the challenge of high growth rate. But according to the Demographic Health Survey, the CPR, contraceptive prevalence rate is stagnant at 34. So we need to control our population by implementing the different strategy to improve family planning services. Next. So objective of my study was to facilitate community mobilization, demand generation, and accessible services for peri-urban areas. Next. So if we, everyone knows that the major cause of female death is pregnancy. And we can prevent these death or maternal mortality by only by birth spacing. Next. Next. So birth spacing and family planning is only the intervention which can decrease maternal death, 33% of maternal death, and unwanted pregnancy, 25% of mortality of children under 5, and 13% of children under 5 by spacing 24 months in the pregnancy. This study was carried out in 4 different areas of Karachi, in 2 districts of Korangi and Malir. In these communities, we have the surveillance data. We are conducting surveillance data, and we have registered all married women of reproductive age and children under 5. And we have conducted this study, approximate population of 372,000, and with Mavras more than 59,000 Mavras in these communities. So we have what we did. The intervention was VPT model for MNCH, the integrated approach of integrated services for mother and child. This is the model. In these community, we are empowering the communities by selecting girls from the community and supporting them for midwifery course. And after the midwifery course, we are hiring them for the services. We have the surveillance team capturing the data after every 3 months, and they have all data in digital platform, and we are measuring through ANC visit, skill birth delivery, and through immunization coverage and family planning services. So in these community, we have antenatal care in the same center, postnatal care, we are facilitating for skill birth delivery, postpartum care, newborn care, and at the same time, family planning services through trained midwives. So we have we use this surveillance data to identify the potential family planning user in the communities. And we have conducted more than 165 sessions with male and female. We address the barrier of male-dominant society. And the focus of these sessions were to communicate healthy timing and spacing for spacing in the pregnancy.
Dr. Noshin, please move towards results and discussion.
Okay. So the result is, after all these interventions, we found the result from the baseline. We compare the data of baseline before and after the end of August, and we found 4.5-fold increase in the active family planning users. So in fact, there were only 714 family planning users in 1 month, and in August, we have enrolled 3,299 family planning users with all these intervention and with integrated family planning services. Next. Please. So conclusion is, this study demonstrates the effectiveness of community mobilization with accessible services in underprivileged areas. Wait forward, please. So with these positive results, the recommendation is to scale up these services in other peri-urban areas of Sindh, Karachi and Sindh, and engaging male and female for addressing the barrier of family planning, and integration of family planning services in existing MNC services to ensure all these services should be available in under one roof. Thank you.
Thank you so much, Dr. Nosheen, and all the participants and speakers. And for discussion of today's session, over to you, Dr. Aisha Babar, Head of the Department Public Health, Al Shifa Eye Hospital.
Assalamu alaikum, everyone. Thank you so much, sir, with your permission. The topic of this the title of this session was very apt to a lower middle income country, that is health system strengthening with innovations. It is understood that jitne bhi 7 speakers they were well spoken, they did their research, especially keynote speaker, and all of them with their different diverse backgrounds and their researches again emphasize the point कि अगर एक lower middle income country में आपने health system के 6 building blocks जो कि governance से लेके आपकी information system से लेके आपकी human resource जो कि आपने gaps identify किए थे कराची की study में, आपकी financing और products और diagnostics ये सारे करने हैं तो local solutions से करने हैं और जो adaptable हो, affordable हो, accessible हो, जिनकी presence में जो कि acceptable हो लोगों को socially भी और politically भी और culturally भी, तो फिर वो फायदेमंद होती हैं. So I think I applaud everyone for their researches and well spoken ideas, and over to the moderator. Thank you so much.
Thank you so much, Dr. Aisha Babar. And now I want our Vadi chair, please, sir, I want to have your few points for today's session.
Thank you very much. Well done, everybody. You did very well. My only observation is that your study had been very good, but the presentation, the skills of presentation, they lacked, especially looking at, because once you are preparing this presentation, you are doing it on your laptop, not realizing that when we'll be watching it, the font size is so small, it's hardly 12 font size, which is not acceptable for a PowerPoint presentation. It has to be minimum 24. So most of the slides you are unable to see. Number one. Number two, I think so that as there is always paucity of time, so most of you have to be within the confine of the limits. So if it's 7 minutes, so try to avoid introduction. Most of the introduction is already known. It has to be 1 or 2 lines. So most of you took actually 7 to 10 minutes introducing the topic. So it's a very good thing, but as Babar rightly mentioned, that probably HSA has to have a workshop on the presentation skills as well. Yeah, thank you very much. Everybody did very well, actually.
Sir, Dr. Babar Taslim, if you want to add something.
Thank you, Simri, for giving me the opportunity to chair this session. मेरा सिर्फ एक comment है. Everybody presented wonderful work. And as we say that in health system, everything under the blue sky is public health. So I was asking myself why I'm listening to fatty liver and why I'm listening to CT scan and why I'm listening to WHO essential diagnostic tests. But then I was, in a way, I was able to relate it with some dimension and some aspect of it. आपने जब बात की diagnostic tests for which people approach you, it matters because there is a cost in it. So somebody who can be diagnosed with a simple ultrasound should not be seen from a CT scan. And this is a question of ethics also, medical ethics also. And our practitioners today, वो बड़ी बेध्यानी में CT scan लिख देते हैं, हालांकि उनको इसकी implications का नहीं पता कि एक आम आदमी की जेब पर क्या बोझ पड़ रहा है इसकी वजह से. And this is what we call as public. And this relates to the paper that Dr. Sabha presented on out-of-pocket expenditure. It's a huge question. एक social protection initiative start हुआ था इस मुल्क में, हर घराने को 10 लाख रुपए देने का, वो हमें पसंद नहीं आया, हमने बंद कर दिया उसको, क्योंकि इससे रिलीफ मिलता है गरीब को, तो रिलीफ तो देना ही नहीं हमने गरीब को इस मुल्क में. तो बहरहाल that was very good. I will concur with Janasa. आप सबके लिए, आप स्टूडेंट्स हैं, पढ़ रहे हैं मास्टर्स लेवल पे, बैचलर्स लेवल पे, कुछ PhD वाले भी मुझे नजर आ रहे हैं यहाँ पे. एक जनरल बात, एक रिसर्च कंडक्ट करने के स्टेप्स होते हैं, एक रिसर्च लिखने के स्टेप्स होते हैं, एक आप रिसर्च सेमिनार देते हैं अपने एकेडमिक इंस्टीट्यूशंस में, वहाँ की प्रेजेंटेशन, कॉन्फ्रेंस की प्रेजेंटेशन जरा डिफरेंट, शॉर्टर होती है, उस पर बहुत सारी ऐसे होती है जिसपे हम लोग इंटरेस्टेड नहीं है. हम लोग इंटरेस्टेड है, हमने 4, 5, 6 लाइक्स मैक्सिमम. और जिससे सर ने फरमाया फॉन्ट साइज का हमेशा ख्याल रखें. आप इस कमरे में इन लोगों को दिखा रहे हैं 10 का फॉन्ट या 12 का फॉन्ट साइज ज्यादा है, ठीक है. और टाइम लिमिट का हमेशा ख्याल रखें, जो टाइम आपको दिया है कि उतने टाइम में जाए. बट आई अप्रिशिएट इतने बड़े फोरम पे आना, इतने बड़े फोरम पे प्रेजेंट करना, इतने लोगों के साथ. You need all my appreciations and your resolutions, and I wish you all the best for future successes. And it was pleasure listening to all of you.
Thank you so much, sir. And I think I am successful in concluding this session at 2. Your lunch is served, but I want to have a group. Okay. The madam, if you want kindly add something.
Everything has already been said, but I would like to deliberated some of the lectures on the evidence-based data, and we have conducted a lot of surveys on evidence-based. It is a research organization, and Pakistan Demographic and Health Survey is being conducted by NIPS. So all the students are invited to do in-depth analysis with us. We have all the expertise. We can help you in presentation, research, and anything. HSA is also interested in, because 2 of my students presented in, she was a researcher, Sidra. She worked with me. So I would like to just invite all of students, PhD, to do the analysis of Pakistan Maternal Mortality Survey as well as Pakistan Demographic and Health Survey. 2 points I'd just like to add. Please before doing the research, confirm it. As the girl said, 3 out of 6. Another woman said that the major cause of death of women is pregnancy. Please don't state such statements. मतलब प्रेगनेंसी तो एक आपका नेचुरल फिनोमिना है, इट इज नॉट मेजर कॉज ऑफ डेथ. मतलब आप एक प्रेजेंटेशन दे रहे हैं और उसमें आप ऐसी स्टेटमेंट दे दें जो सुनने वाले उसमें से जिसको अगर नॉलेज नहीं है तो वो समझेगा वाकई इट इज अ मेजर कॉज ऑफ डेथ. तो इन चीजों को पहले डेटा को, रिसर्च को एनालाइज करें, उसकी मेथोडोलॉजी कंफर्म करें और फिर करें. थैंक यू वेरी मच.
Thank you so much.
Dear speakers, please come for a group photo. एक अपने ग्रुप फोटो लेना है, आप सारे चेयर्स के पीछे आ जाए, एक ग्रुप फोटो। थैंक यू।
ये कवर कर लेगा।
ये कवर करेगा।
सर जी
फाइट करो, फाइट और आने वाले और ये सेटिंग्स प्रॉब्लम हो गई। मैं आगे बाकी भी देखता हूं। ओके, वो बोल रहा है पीछे में आ रहा सेक्शंस प्रॉब्लम, फिर आप वीडियो दे दो, ठीक है। ओके, नाउ वेट, कैमरा साइड रेडी, यस, यस, एक वीडियो टाइम
थैंक यू।
हेलो हेलो
सर लाइव सर ये ना मतलब बात नहीं वो देखा हाँ होगा
आज भी खाना कैसे जा रहा है? आप लोग को भी झटका मानिए जब बढ़ मेरा फोन शुरू हो गया
तो वो मैं सेम से स्टार्ट करूँगा, स्क्रीन शेयर करके उसको ठीक होगा, ठीक होगा।
इधर प्रॉब्लम पर नहीं आता हॉल में जो काम नहीं मैं मॉडरेट कर रही हूँ, मैं नहीं बुला सकती, प्लीज उसको भेज रहे हैं। नहीं उन्हें कहिए कि आज से हमारे सेशन स्टार्ट हो रहे हैं प्लीज। आपका क्या रोल है? आशा भी आपने करी
कितनी देर में स्टार्ट मेरे से आप अंदर तो मैंने शेयर किए
Good afternoon, everyone. I'm Dr. Rujit Sikhar, moderator of this session. I'm really sorry for the delay. The previous session was ended a bit late, due to which there was a lunch break. Right now, there is a lunch break going on outside. But we will try to start it now, and the participants will join gradually. I request everyone to be seated so that we can start. Who is handling the virtual participants? Do we have any virtual participants?
Ma'am, excuse.
So the theme of today's session is universal health coverage and social protection. Today it's Universal Health Coverage Day being celebrated, which is celebrated annually on 12 December and is promoted by WHO, and it is the anniversary of the first unanimous UN resolution that called for all nations to provide for their citizens affordable and quality healthcare. We know universal healthcare is promoted as an instrument to help advance the more broadly conceived human health right to health, which is based upon a number of international agreements or widely affirmed international documents. Universal health coverage has been instituted in the new SDGs as well for 2015 to 2030, adopted by the United Nations. In many nations, inclusive healthcare. We have. I will introduce the panelists. We
malnutrition with persistent high burden of undernutrition, micronutrient deficiency surge in the incidence of the chronic diseases. This issue has been highlighted at the various forums. It has been under discussion. However, the evidence regarding the influence of lifestyle behavior remain under research. Next, please. Next, please. So the objective, basically, we want to bridge this learning and practice gap. We have knowledge, but we are not practicing it actually. So in order to fill this research gap, the current study aims, basically, it was the objective were twofold. First was to assess the self-reported lifestyle behavior among 5 different professionals. And the second objective was to find the association of socio-demographic variables with the lifestyle behavior of different professions using a validated tool, which is abbreviated as the SMILE tool. Next, please. Basically, this was a cross-sectional survey. It was conducted in a twin city, and the participants were basically belong to the 5 different professions, namely, they were mainly teachers, doctor, IT professional, laborers, and we conducted this study over the period of 1 year. We started in last year, August, and this study is completed in 2023 August. Sample size was calculated by taking the margin of error as a 5% and confidence interval 95. The sample size estimated was found to be 400. We used a non-probability convenient sampling technique to recruit a 400 participants. Next, please. Basically, the basically the results were showing that the significant association was found with respect to the gender. Then next was with respect to the occupation. In gender, we found that the male, being the male, is associated with the poor lifestyle, and similarly, younger age is associated with the poor lifestyle. And among the occupation, the banker has a worse score, while teachers have a better scores. And in income, there was not a significant association in the being resident of Sindh province was significantly associated with a lower SMILE score. Next slide. So this is basically, the slide is showing the mean SMILE score in lifestyle domains across 5 occupations. These are occupations and these are 7 domains of SMILE inventory. So here we can see that the diet and nutrition was poor among doctors. And next was substance use, which was poor among the then physical activity was voted lowest in teachers, and stress management was lowest in doctors. Restorative sleep scores were also lowest in doctor. Social support mechanism was poor in bankers and environment. The striking feature is that being healthcare professional, being a doctor by profession, is associated with the poor diet and nutrition, poor stress management, and poor restorative sleep. Although we doctor are major stakeholders of our health, but still the scores were poor among the doctor. Maybe it can be due to the imbalance work life, poor balance between the work and the professional life. And even the evidence is also supporting that the doctor are very they are not good in their own health seeking behaviors. So they can be a multiple reason, but the most striking reason which has been reported in the literature is that it's a poor work-life balance basically. Next, please. So from this study, we concluded a series of demographic variables which include male gender, younger age, banker by profession were found to be associated with the lifestyle behavior. Our study has meaningful results among the different occupations across the 5 lifestyle domains. The finding highlight the importance of incorporating healthy lifestyle practices and the need of targeted lifestyle intervention to promote health in the community. Next, please. The present However, there are few limitations in this study. The present results are conducted it was conducted as a cross-sectional study, and hence we use a non-probabilistic nature of a sampling technique. So it's difficult to generalize the results. And moreover, we conducted it among the 5 different professions who are already very learned and educated people, which can also influence the results of this study. And we anticipate that in future, we want to conduct a longitudinal study and with some sort of an intervention to see the impact of intervention on the lifestyle behavior. Next, please. Here I would like to acknowledge the effort of our 4th year MBBS student at Rawalpindi Medical University and my colleague Dr. Narjis Hadi, who helped me in collection of data for this study. And not last but not the least, our teachers and supervisor at Health Services Academy, because I took elective course of nutrition at HSA, and this was a major stimulus. The course was run by Professor who have some sort of a cross-sectional study which provide us as baseline data for future interventional study. So this was a main source for me at least to conduct this study. Next, please. So these are the references for this study, and thank you very much for this.
I'm sorry, silent का भी और बड़ी डिस्टर्बेंस हो रही है, इसलिए वहाँ पे बात करेंगे वो बाहर चलेंगे उनको silent का और issue.
Thank you very much. Thank you, Dr. Paula, for your presentation. Your study is indeed very crucial for promoting universal health coverage and social protection, and understanding how various professionals engage in health-related behaviors allows for tailored interventions that can contribute to preventive measures and overall well-being. And these targeted health policies can ensure effectiveness in achieving the universal health coverage goals. We agree that doctors have a poor lifestyle due to demanding work schedules and high stress levels, emotional exhaustion, and limited time for self-care available to them. We will again take the Q&A session at the end of all presentations. With that, I invite our next speaker, our very own faculty member, Associate Professor of Health and Health Economist, Dr. Tariq. He's also serving as registrar at Health Services Academy. The title of his presentation is The Impact of Health Expenditures on Economic Growth in Selected Southeast Asian Countries. With that, I hand over the floor to Dr. Tariq.
Thank you.
Sir, kindly.
Ladies and gentlemen, Assalamu alaikum. So, as well as topic is the impact of health expenditure on economic growth in selected Southeast Asian country. Why? I mean, why we are selecting this topic? The importance of this topic. First of all, this is a very important topic. What is the impact of health on the economics? What is the impact of health expenditures on economic growth and employment. There are a lot of studies available in the different countries and Europe and highly developed countries, but unfortunately, such like a study is not available in our regions, especially South Asian regions. So that is why we have decided that this study. This is a purely study about the primary data, especially STEM data, related to STEM data and analysis, and how we can find the impact of health expenditure on economic growth. Almost in the European countries and there are a lot of, there are two or more important studies like Canada and available. What is the impact of health expenditure on economic growth? But we try to find out, and we select, for this study, we selected 8 countries. Okay. 4 countries from East Asian regions and 4 countries from South Asian regions. South Asian regions, Pakistan and India, Bangladesh and Sri Lanka. And from the East Asian countries, the 4 countries, India, Japan, Malaysia and China. Why we are selecting these countries? Next. These are the 8 countries on the map. Why we are selecting the group of these countries? These 8 countries appear on the map of the world on the same map, except Bangladesh. As you know, Bangladesh is the part of Pakistan and it's 1971. So these 8 countries. While next please. Next please. This is the scenario. Sometimes a few years ago, the South Asian countries far ahead the East Asian countries. While now the East Asian countries are far ahead than the South Asian countries. What are the reason behind it? This is the reason we are selected these 4 countries for comparative analysis, the East Asian countries and South Asian countries. So this is the can you next please? The trend in current health expenditure, you can see. मेरे ख्याल इससे बेहतर ये मतलब ऊंची हो जाएगी बात क्योंकि प्रोफेसर है तो भाई बात वैसे आएगी आपको वहां पे so these are trends in health current expenditure. Look at this graph. The health expenditures of these East Asian countries is going up and up, but every year is increasing their health expenditures. But it's unfortunately in our South Asian country scenario is different. But my beloved country, Pakistan's, looked at data is not more than 0.2%, 2%, 1.9, 2%, not more than 8% of GDP. So while everybody knows the required health expenditure data as estimated by the big 5%, but unfortunately we are unable to gain the 5%. Next, please. So these are the 3 basically objectives: to investigate the short and long run directions of the association among these healthcare spending and national economic growth, to find out the association between the economic and the health expenditure, and second, the connection between examining the health expenditure and national economic growth by examining the variation patterns and potential factors with SEC, South Asian countries. To investigate whether there is a long run associations exist among the economic growth and the public healthcare expenditure, as well as in the direction of the energy between the two. Next, please. So these are the models. This is the model. Generally, it's the first the functions. Economic growth is the function of health expenditures, health indicators, and trade, and household consumption. This is a mathematical models. And when we convert it into equation form, it becomes like this. The economic growth, the GDP per capita, we use the GDP per capita as a proxy for economic growth. So GDP per capita is equal to this become equations. Beta 1, health expenditure per capita, health consumption per capita, life expectancy, labor force, and trades. Our variable concerns is health expenditure per capita. So, next please. These are the diagnostic tests. We use the data from the World Welfare Indicators and from 2000 to 2020. It's almost 20 years data. So we perform, it's a time series analysis. It's so the time series panel data. We perform the diagnostic test. All the tests are very sound. Normal tests, there are no normal tissues, heterostaticity, no problem of heterostaticity. This is a highly technical statistical terminology. Stationary testing, the stationarity and difference, some are at level, including labor force and life and all they are seeing at first difference. And lag will stack the second lag. And panel control degradations is also exists between the variables for the association between the two variables. So, next please. These are the results of the pairwise gradient genetic test. This gradient resistance basically commonly used in the formatic studies and economics. Basically, the concept of this test is to show the correlation between the two variables. Economic development is linked with economic growth, and economic growth is linked with economic development. And similarly, health expenditures, if you have a more health expenditure, then you have a very good economic growth. If you have very good economic growth, then you have very good health expenditures. I guess. So let's show the correlations. Mostly, our variable of concerns, the health expenditure does not granted as this is a null hypothesis. GDP per capita, it is almost non-significant in South Asian countries. It shows no correlation between the health expenditures and economic growth. So there are a lot given in this slide. Next, please. Then next. So this is a very important the final results of panel regression results. The East Asian the equation we have already shown the result of these equations. This coefficients of panel OLS orderly least squares and fully modified orderly least square and dynamic orderly least square. There are three models which are used. This is highly basically formulaic techniques used for the association between the different variables and to find out the impact of one variable to another variables. So this is the models in the simple OLS regression results. You can countries. In the East Asia, they are not a significance. Health expenditures, impact of health expenditure on economic growth. Economic growth between GDP per capita as a dependent variable, while all other are the independent variable. So this you can say the probability p value is more than 5. So they are insignificant. Similarly, in FMLS, all these are insignificant. Why they are insignificant? Either the EAC have no impact of health expenditure on economic growth. Yes, there are reasons because they have achieved their optimum levels. They have to find out the impacts. They have to invest a lot of money. While if you invest very low money on health expenditure or health, you can get more results. Next, please. And then the South Asian community. This is a totally different results. This is totally different than all the variables are significant and have significant associations with the economy. Like that 0.4% significant and FMOLS and DOLS, all they are variable are significant. So health spending for South Asian countries is substantially co-integrated with economic growth and a large at 5% levels. It demonstrates that one year shift in health expenditure lead to 1.3% economic growth. It means if you 100% increase your health expenditure, your economic growth will rise 1.3%. This result shows. So all these results depicts and indicate that it is direly need to invest a lot on health. We have to increase our health expenditure, especially in Pakistan. Next, please. So this is a slightly comparison of the both slides. Next, please. So the study sports all of these none of all these studies is shown that Raman Road and that is highly associated with each other and has impact a lot and some regions country as compared to these Asian countries. Because these Asian countries have achieved their optimum level, although they invest a lot of money, but the impact is very low. Why they have to invest a very small amount of money per have, and we can get a more results. This is the greatest chunk of results. So the result of study also this revealed that the impact of factoring on economic growth and development high range as compared to AC. This indicate that the EAC have achieved optimum level in the universal health coverage, while the South Asian countries are still lagging behind and achieving the optimum level in USC. Therefore, South Asian countries should invest more on USC for better health and economic growth. Next please. So what are the policy implications? We suggest 3 policy implications. The South Asian countries should invest on health sector to achieve the optimum level, nurturing the human capital and resultantly enhancing the economic growth and development over the time frames. In the South Asian country, pool their funds to 5% of GDP as recommended by WHO by enhancing public financing and cultivating public health services for all. They reduce out-of-pocket payments. Slowly, through public fundings and equitable participation in the country budgets be granted, ideally accomplished via progressive taxation, while healthcare is accessible to everyone and based on their medical requirements. And the most important suggestion in this article is that we can earmark the budget. Like that, we can tax on fizzy drinks, we can tax on cigarettes and smoking articles, and we can enhance the budget of health. This is basically very important our role to give insight for the policymaker and public health specialists. Thank you very much. This is our
Thank you very much, Dr. Tariq. We were a bit scared how to stop you. Sir, being our very beloved professor, it was the first time that we were going to stop him in a couple of minutes, but sir ended already in time. Thank you very much. Moving on. So with that, I would also like to tell that yesterday on 11 December, WHO issued calls on government for urgent action to invest in universal health coverage. The report was published in 2023 Global Health Expenditure Report, which sheds new light on the evaluation of global health spending at the height of the COVID-19 pandemic. Released ahead of the UHC date today, which is today, 12th of December, the report revealed that in 2021, global spending on health reached a new high of US $9.8 trillion, or 10.3% of global gross GDP. Nevertheless, the distribution of the spending remained grossly unequal. Public spending on health had increased across the world, except in low-income countries where government health spending decreased, and external health aid played an essential supporting role. In 2021, about 11% of the world's population lived in countries that spent less than $50 per person per year, while the average per capita spending on health was around $4,000 in high-income countries. Low-income countries accounted for only 0.24% of global health expenditure, despite having an 8% share of the world's population, which highlights the gross inequities that are present in the world related to health. Again, thank you very much, Dr. Tariq. Moving on to our last presenter of the day, Dr. Amber Rizwan. Dr. Amber Rizwan is going to present barriers on HPV vaccination among female university students of Quaid-e-Azam University and Fatima Jinnah University. It is a phenomenological study in Islamabad and Rawalpindi. Dr. Amber is a public health professional with 15 years of experience working at primary and secondary healthcare level in the province of Punjab and at federal level. She has worked as a medical professional in PESI and Punjab Health Department in various dispensaries and hospitals between 2007 and 2019. During this period, she also worked in tertiary care hospitals in the areas of medicine and psychiatry. With her vast clinical experience, Dr. Amber shifted to a career of an independent public health professional. She has completed her master's in public health from Health Services Academy, Islamabad. Over the last few months, she has been working for WHO and NDMA as a public health and health system reform expert. Her field of health sector expertise include women and child health, waterborne diseases, hospital management, health systems, vaccination drives, and psychiatric services. The floor is yours, Dr. Amber.
Thank you, Anuj, for my introduction. So I would like to present my topic of discussion today, barriers on HPV vaccination among female university students of Qaid-e-Azam University and Padma Jinnah University. It was basically a phenomenological study among the twin cities, in both of the twin cities. So in my introduction, I would next. Since I would like to introduce the topic, the background of the topic in which I carried out the research was that the cervical cancer is the third most leading cause of the cancer among women aged between 15 to 45 years old in Pakistan. Each year, about 5,008 women are diagnosed with this cancer and 3,197 die from this disease. Cervical cancer ranks as the third most frequent cancer among women in Pakistan and second most frequent cancer among women between ages of 15 to 44 years of age. An estimated 4,742 women would die from this cancer by 2050 if in the absence of the preventive measures. So the causative factor, cervical cancer is mostly caused by human papillomavirus. Next. HPV vaccination is being seen as one of the most important instruments for preventing incidence of cervical cancer all over the world. So Pakistan is becoming a hotspot for HPV transmission, which is still widely overlooked as a risk factor for this cancer. Present research undertaken as a phenomenological study to identify and understand the barriers which are able to roll out the wider usage of HPV vaccination among the women and the girls for the protection against this cancer. In my research question, I added that why there is less use of HPV vaccination among girls and women in Pakistan, and what are the barriers to HPV vaccination among the girls and women. So, and what are the underlying and inhibiting factors which contribute to the lack of the awareness about this cancer and willingness for the HPV vaccination among girl students, especially female girls between 15 to 44 years of age. In literature view, I conducted a qualitative study and taken a review from all the studies previously done from Pakistan, Brazil, USA, and India, covering similar themes, providing regional comparison. So in this research, it was the technique to highlight the subjective experiences and perspectives of the respondents and how these are used to arrive at different conclusions by the people, especially I choose the female university students. So purposive sample technique was purposive sampling technique. Purposive sampling technique. Yes, purposive sampling technique, which was based on specific selection of sample, which has a likelihood of answering that question. So I choose the female university students so that they will answer my questions. In this selection of university students, present search was based on assumption that higher qualification mean better knowledge about this cervical cancer. Next. It was a methodology, it was a qualitative research in which a pre-designed interview guide was made and selected respondents were identified by using the pre-designed interview guide in both of these universities. A total of 35 interviews were made, including 15 at Qaid-e-Azam and 20 at Padma Jinnah University. And all the respondents were included 33 students of bachelor's and master levels. Alongside, I took 3 faculty members of each of the university, basically the head of department or associate professors, females only. Included criteria was that students and teachers, and excluded were that they were like vaccinated, HPV vaccinated respondents, or even I rejected the married females. In my results, results were based on the questions I asked from these students. My questions were whether this incidence is high in Pakistan or not, can be treated through vaccination or not, whether HPV vaccine exists to treat this cancer, or whether the HPV vaccination is beneficial to control the cervical cancer, and whether HPV vaccination should be part of overall vaccination program drives, and prevalence of fears and apprehensions about HPV vaccination among the students plus faculty, teachers, faculty members. Identification of steps to enhance the usage of HPV vaccination. So these questions were based according to them, according to this criteria. Major I find after that interview I have done in both of these universities. So major reason I found out for the non-usage of this vaccination was that most of them were agreed that awareness issue is the main component behind the lack of use of HPV vaccination. So awareness issue was highlighted more. Then there were cultural and social taboos which were preventing the girls to seek the information. Mostly the parental permission and other cultural stigmas. And all of them, there is affordability issues also and availability issues also, that vaccination is mostly not available as a regular vaccine drive in EPI schedule. So they were reluctant to find out that availability issues were also the major component. Further, in the result, which I significantly find from the data, that most of the respondents have limited or no information about cancer and HPV vaccination. Majority of the respondents were unaware of the exact extent of the spread of the cancer and exact HPV vaccination benefits. Many respondents did not have any knowledge about HPV vaccine, but agreed that it could be made a part of the vaccination drive, so that the people can start taking it after knowing its benefit and any likely side effects. And most were also agreed in my result that social media campaigns and student focusing messages were indicated as the most effective tool for spreading the awareness on HPV vaccination. For majority of respondents, parental permission and addressing social taboos was also important. So, in further conclusion of my research, the key research questions for this research was aimed to explain why there is less use of HPV vaccination in Pakistan among girls and women as protection against this cancer. And the result of the study was helpful in identifying the reasons of lack of awareness about this cancer and about the causes resulting in the usage of HPV vaccination among women. Major contribution of present research is to identify the list of factors which were responsible for the attitude and the behavior of the educated women towards the phenomena of cervical cancer. Plus, HPV vaccination is the only preventive measures to get rid of this precancerous lesions. So study also suggests concrete measures to enhance the HPV vaccination coverage. Major limitation of this study was that most of the respondents were hesitant among answering the basic personal questions. Basically, students and teachers, they avoided some time to discuss this cervical cancer and their fears associated with the side effects of COVID-19 vaccination. Most of them, they have fears that it has side effects regarding because it is likely the first age is 9 to 12 years old female are vaccinated against this human papilloma virus. So the fears associated with this vaccine was a lot in comparison with the COVID-19 vaccination. But most of them were likely, they were encouraged if the vaccination drive in similar to COVID-19 should be able to, if government allowed to set up this vaccination drive, so they can they can use this vaccine. In my suggested future research, I can look into how previous vaccination drives and social taboos have all adversely impacted even scientifically proven clinical remedies in our society. So my main recommendation in this study was that enhance use of social media for promotional healthcare programs, in addition to using conventional print and electric media for the awareness raising about the HPV vaccination. So mostly I recommend these recommendations for the and plus government policy decisions to enhance this vaccination among the usual EPI's immunization schedule, as it is done between the girls students of 9 to 12 years old. And plus education of male is also important in my recommendations. Thank you, sir.
Thank you very much, Dr. Amber. With that, I will invite our final keynote speaker, Dr. Adnan Bhutto. Dr. Adnan Bhutto is the project director for HCID, which is the Healthcare in Danger Initiative, and he's working at Jinnah Sindh Medical University and Apna Institute of Public Health as well. Dr. Adnan Bhutto, please. Dr. Adnan has worked extensively on de-escalation of and managing violence against healthcare workers. He's a graduate from Hamdard University, Karachi, and then pursued a master's degree in public health from Dhaka University of Health Sciences.
Assalamualaikum. Thank you so much, Dr. Rubin, for the nice words. So, I'm working as a project manager for HCID initiative, Healthcare in Danger Initiative, which is run by ICRC, International Committee of Red Cross, and collaboratively AIPH, Apna Institute of Public Health, Jinnah Sindh Medical University, Karachi. It was started basically in 2014 with the theme that is there any violence against healthcare workers happened in Pakistan or Karachi? Yes or no? Just on that. And then our respondent, Professor Lubna Ansari Beg, at that time, she's the dean of AIPH. She just replied to that, yes, it happens with us in so many areas, but it never reported in such a way that it can be highlighted. So, after that, ICRC decided to make a research study on it, get the data, then we can find what we can do with this. So, a study is taken for just 6 months data, and the results were too much different. Violence हमारे यहाँ अमूमन हम लोग उसको feel नहीं करते, because it is an internal administration which can be intervened and the things will be sorted out. Whether वो चाहे उनको physically मार के चले गए, ठीक है, या verbally abuse किया जाता है, mostly health workers को, जैसे हमारे staff हैं या phlebotomists हैं, उनके साथ ये मसले बहुत ज्यादा होते हैं। या first responders अगर कोई ER के अंदर है और डेड बॉडी आ जाती है, तो उसमें वो क्या करते हैं, उनको हरासा करते हैं, ठीक है। तो डॉक्टर्स के साथ भी बिहेवियर अच्छा नहीं होता, किसका, अटेंडेंट्स का। और मॉब की सूरत में हमारे हॉस्पिटल्स में इमरजेंसी के अंदर वो पेशेंट के साथ आ जाते हैं, तो उसको सिचुएशन को कवर करना सिक्योरिटी गार्ड्स के लिए काफी मुश्किल हो जाता है। तो इसी के हवाले से फिर एक रिसर्च स्टडी की गई, जो हमने यहाँ पे भी शो की थी, उसको थोड़ा नेक्स्ट कीजिएगा आगे। वायलेंस होता क्यों है हमारे यहाँ? According to WHO defines, violence is the intentional use of physical force or power, threatened or actual, against oneself, another person, or against a group of community. Likelihood of resulting in injury, death, psychological harm, maldevelopment. ये तो WHO ने कह दिया है कि अगर से किसी के साथ ये चीजें होती हैं तो वो इन चीजों की वजह से होता है, इंटेंशनली होता है कोई भी, और जिसकी वजह से हमारे पास जो नताइज हैं वो काफी खराब होते हैं हेल्थ के वर्कर के ऊपर बर्डन आएगा, जैसी बात है वो फिर उसको काम करने का दिल नहीं करेगा, ठीक है। तो जस्ट एक स्टडी की गई और उसके बाद जब देखा गया रिजल्ट्स कि वाकई ये होता तो है, लेकिन क्यों होता है, उसकी भी वजूहत तो होती होंगी। अटेंडेंट ऐसे तो नहीं सकते हर डॉक्टर के साथ या स्टाफ के साथ मिसबिहेव करेंगे, या सारे ही मरीज ऐसे नहीं होते जो इस तरह की कैफियत में होते या वो इस तरह लड़ाई झगड़ा शुरू कर दें। तो उसकी कोई वजूहत होती है, उसमें कुछ खामियां हमारे हेल्थ के वर्कर्स के लिए भी। ठीक है, उनको भी कुछ सीखना चाहिए और किस तरह कम्युनिकेट करें। तो उसी स्टडी के अंदर जो रिजल्ट फाइंडिंग्स आए उसमें है कि कम्युनिकेशन गैप है बहुत, हम लोग अपना मैसेज डिलीवर नहीं कर पा रहे, अगले ने मैसेज कुछ और परसीव किया, हम कहना कुछ और चाह रहे थे, जिसकी वजह से चीजें खराब हुई और वायलेंस की तरफ बात चली गई। तो उन चीजों को हम विद इन द पैसेज और पेरिफेरी हम उसको कवर कर सकते हैं, ठीक है, विद डी एस्केलेशन ऑफ द टाइम। क्योंकि एस्केलेशन होती है तो कोई ना कोई वजूहत होती है, ठीक है, कोई बात आपने किसी को बतानी तो वो समझ नहीं पाया उस तरह, या मैसेज कर लिया आपने कर दिया वो परसीव नहीं कर पाया। तो आपको सबसे पहले कम्युनिकेशन पर अपने काम करना है। हमारे मेडिकल कॉलेज में और नर्सिंग इंस्टीट्यूट में, अलाइड हेल्थ साइंसेज में काम ज्यादा होता है क्लिनिकल के हवाले से। हमने जो चीजें दे दी, आपने बुक्स पढ़ ली, एटलीस्ट कर लिया, हमने नहीं किया था, हम भी पढ़ पढ़ा के आ गए सब चीजें। लेकिन जब लोग टाइम वार्ड में खड़े होते हैं और वो एक डिफरेंट सिनेरियो होता है, हर पेशेंट हर के साथ अलग अलग अटेंडेंट्स होते हैं, आपको कहीं से आवाज आ रही है, कहीं से आवाज दे रहा है, और उस वक्त आपको किस तरह कम्युनिकेट करना है अपनी बात और हर पेशेंट को सेटिस्फाई बीइंग अ हेल्थ केयर प्रोफेशनल सब आवर ड्यूटी, मेरे को रिस्पांस देना है। लेकिन उसका फिर एक नतीजा ये होता है कि अगर से वो बात समझ गए तो दैट्स गुड, नहीं समझे तो फिर क्या वायलेंस किया जाए, ये तो कोई हल नहीं है ना। किसी भी और डिपार्टमेंट में अगर आप चले जाते हैं या बैंक वगैरह में कभी जाते हैं तो क्या होता है, वहां तो वो अगर लाइन लंबी है तो आप उनको बोले हमें हेल्थ केयर वर्कर है, हमें जल्दी जाना है, आपको डिटेक्ट करेगा कभी, तो लाइन चल रही है उसके बाद, या लंच ब्रेक होता है तो लंच ब्रेक से पहले आपको डिटेक्ट कर सकते हैं। लेकिन जब हॉस्पिटल में आते हैं या हेल्थ केयर वर्कर्स के साथ कोई इंटरेक्शन होती है किसी की, तो उसका यही होता है एंड प्रोडक्ट के हमें जल्द से जल्द फायदा मिले या हमारी बात पहले सुनी जाए एज कम्पेयर टू अदर। सो यही वो चीजें हैं जो हम देखते हैं। नेक्स्ट दीजिएगा। प्रोएक्टिव एंड रिएक्टिव वायलेंस, दो किस्म के वायलेंस, जो रिएक्टिव भी होते हैं या प्रोएक्टिव। हम जिस पे काम करते हैं वो है रिएक्टिव वायलेंस। नेक्स्ट प्लीज। नेक्स्ट, emotional, angry, effective aggression to take revenge, or to retaliate to provocation carried out in anger and frustration in a heightened emotional state. Use de-escalation strategies. Next, जो हम लोग फेस करते हैं अपने हेल्थ के वर्कर्स जो हमारे फेस करते हैं वो रिएक्टिव वायलेंस होता है कि उसी वक्त कोई आपने उनको कोई चीज बताई जो उनको ना बोलनी, उसी वजह से उन्होंने आप पे अटैक किया, फिजिकल, वर्बल और समथिंग, या चीजें उठा के मारना या डैमेज करना प्रॉपर्टी, ठीक है, या हरासा करना, आपको बोलेगा अच्छा बाहर आगे जरा, ठीक है। तो इन केस सब चीजों के अंदर हमें डी-एस्केलेशन करना आना चाहिए। तो पहले तो ये चीजें होनी ही नहीं चाहिए, सिक्योरिटी हमारी इतनी अच्छी होनी चाहिए, एडमिनिस्ट्रेशन का काम इसमें आता है कि उन्होंने किस तरह इसको डील करना है, सिक्योरिटी गार्ड किस तरह होने चाहिए, वो किस तरह उनको रोके, मॉब को आने देना नहीं चाहिए, 101 पेशेंट पॉलिसी होनी चाहिए, जो कि मोस्टली पब्लिक हॉस्पिटल में करना काफी मुश्किल है, लेकिन ये हो सकता है, इट कैन बी अचीवेबल। प्राइवेट हॉस्पिटल कर रहे होते हैं, लेकिन हमारे यहाँ थोड़ा सा सुविधान होता है, गवर्नमेंट की लोड ज्यादा होता है। नेक्स्ट प्लीज। सो दीज आर आवर पार्टनर्स in health and danger initiative project by ICRC, Aman Health, ED, Indus Hospital, and अपना जो पब्लिक है JPMC, Madam Jamali is also a great part of our this project. Next, यही वो सवालात थे जो इस स्टडी में पूछे गए थे, वायलेंस कौन करता है, किसकी तरफ से होता है, और उसके बाद क्या होता है। तो ये 4 लार्ज सिटीज में हुआ था, जिसमें कराची, पेशावर, इस्लामाबाद, लाहौर एंड 4 डिस्ट्रिक्ट ऑफ 3 प्रोविंसेस Sindh, Punjab and KPK was involved. Respondent 8,579 healthcare workers were included, जिसमें डॉक्टर्स भी थे, नर्सेस भी थे, पैरामेडिक्स भी थे, सिक्योरिटी गार्ड भी थे, एम्बुलेंस वर्कर्स भी थे। नेक्स्ट प्लीज। सो ये वो डेटा है, कुछ 33.9% जो है वो एब्यूसिव और शॉक एंड थ्रेटनिंग को फेस करते हैं जिनके साथ हुआ था एक्सपीरियंस। तो ये टोटल है 2909 among 8,579। नेक्स्ट प्लीज। 1578 was witnessed, कि मुझसे नहीं, मेरे साथ नहीं, लेकिन मेरे कुलीग के साथ हुआ था कि मैंने वो देखा था या नोटिस किया था कि किसी के साथ जब मैं ड्यूटी ऑफ कर रहा था उस वक्त मैंने देखा था कि वायलेंस हो रहा था। ठीक। नेक्स्ट, रीजंस फॉर फिजिकल वायलेंस, डेथ ऑफ अ पेशेंट। अगर कोई पेशेंट एक्सपायर हो जाता है तो उस वक्त अगर आपने ब्रेकिंग बैड न्यूज सही तरीके से नहीं की तो चीजें खराब हो सकती है। और ये कोई ऐसी वो बात नहीं है कि सिर्फ आम आवाम ही इस तरह हमारे साथ करती है, नहीं, कोई और भी है। अगर आप उस जगह पे होते हैं और आपकी किसी प्यारे की इस तरह की न्यूज आपको सुनने को मिलती है तो आपकी हो जाएगी परेशानी। तो वो रिएक्शन आ सकता है। ठीक है, बी रेडी फॉर दिस कि हाउ यू गिव बैड न्यूज और किस तरह आप उनको बताएंगे, किनको बतानी है ये भी इंपॉर्टेंट है और किस तरह बताना। So next please. Reason for verbal violence experience ये जिनके साथ हुआ था, next करो। So healthcare workers are working in an environment characterized by a multitude of conflicts and types of violence. They lead to stress और PTSD। बिल्कुल, अगर किसी के साथ कंटिन्यूसली चीजें होती रहेंगी तो क्या उसका काम करेगा, नहीं करेगा। इसी तरह काफी टाइम पहले हमारे काफी डॉक्टर और स्टाफ यहाँ से चले गए। मुझे छोटे जाहिर सी बात, जब ऐसी जॉब के अंदर आपको खतरा हो, ठीक है, वायलेंस का, तो आप कर पाएंगे वहां पे, कोई भी काम तो नहीं कर सकते आप। नेक्स्ट प्लीज। De-escalation and managing violence. Next please. Next. Escalation क्यों होती है? When someone is judgmental. डॉक्टर, स्टाफ और हेल्थ केयर प्रोफेशनल तो कसाई होते हैं, उनके सीने में दिल नहीं होता। ठीक है, ये मशहूर टैगलाइन चल रही होती है।
ऐसा है या नहीं?
कम है टू सम एक्सटेंट, लेकिन दे आल्सो फील। अगर वो फील करने लग जाए तो वो प्रैक्टिस नहीं कर पाएंगे। तो वी हैव टू डील विद दैट आल्सो। Escalation happens because both people are trying to convey what they need, neither one is listening. अब अगर डॉक्टर कहे कि मैं बहुत अच्छे से जानता हूँ चीजें, आप रहने से आप मरीज हैं, या आप दवाई की वजह से आपको कुछ नहीं पता, और वो भी शाउटिंग कर रहा है, आप भी शाउटिंग कर रहे हो, तो कुछ हो नहीं सकता। So next please. So these are the factors which lead for the escalation, delay in care, death of a patient, serious condition of patient, stop attendants to enter या ये भी होता है। कई बार सिक्योरिटी गार्ड रोकते हैं कि नहीं अंदर जा सकते हैं, ये तो उसमें तो वो हाइपर होना शुरू हो जाते हैं। नेक्स्ट प्लीज। नेक्स्ट फिल करते रहिए। ठीक है, हमने ये चीजें इंपॉर्टेंट है कम्युनिकेशन, ये आप अपने पास ध्यान रखी कर लें कि किस तरह आपने बेहतर करना, इंपॉर्टेंस ऑफ द कम्युनिकेशन। ठीक है, अगर किसी के साथ आप डील कर रहे हैं तो आपको पता होना चाहिए कि उसकी जबान सबसे पहले इंपॉर्टेंट रोल प्ले करती है। हमारे यहाँ जो आप डॉक्टर्स हैं माशाल्लाह बहुत अच्छे हैं, पढ़े लिखे हैं, सब कुछ है, लेकिन दे आर यूजिंग डिफरेंट लैंग्वेज। अब अगर इंग्लिश में सब चीजें उसको समझा देगा, लेकिन पेशेंट लैंग्वेज तो कुछ नहीं पता गाँव से उठ के आया है, और उसके बाद तो उसकी जबान में अगर उसके साथ टच में आ जाता है तो वो काफी खुश होता है। ठीक है, और वो जो सब कुछ बता के चला गया अंग्रेजी में, तो इतना हो जाएगा कि यार मुझे कुछ बताया कुछ और नहीं क्या था। ठीक है, आपने जो बताया, हाँ अब बात समझ में आई और सारा मसला हल। तो मोस्टली ये कम्युनिकेशन गैप जो होते हैं वो हमारी तरफ से ही होता है, हम अगर उसको बेहतर कर लें ज्यादा अच्छा है। दूसरी चीज है, नेक्स्ट चीज, नेक्स्ट एक्टिव लिसनिंग, सुनना है। हमारे यहाँ सुनते नहीं है। अब आप मोबाइल पे लगे हुए या कुछ और काम कर रहे हैं, पेशेंट अपनी कंप्लेंट सुना रहा है, तो क्या समझेगा? आपने सुना ही नहीं उसको, जब आपने सुना ही नहीं तो फिर वो कैसे डील कर सकते? नेक्स्ट प्लीज। नेक्स्ट। सो हम लोग HCID में हमारा वे फॉरवर्ड ये था कि जब वो स्टडी सामने आई उसके बाद फिर हमने ट्रेनिंग डेवलप की हेल्थ केयर प्रोफेशंस के लिए। मुख्तलिफ जितने भी हमारे मेडिकल कॉलेजेस हैं उसमें फाइनल ईयर और हाउस ऑफिसर PG, उनके साथ हमने ट्रेनिंग डेवलप की, उनको हम ट्रेनिंग दिया करते थे, मास्टर ट्रेनर में तैयार किए। इसके साथ साथ नर्सिंग इंस्टीट्यूट के अंदर कराची में मोस्टली हो चुके हैं, इस्लामाबाद में काफी सेशन हुए हैं, यहाँ पे भी हमारा पार्टनर रहा है इसके साथ। और उसके बाद फिर हमने काम किया लॉ के ऊपर, कि लॉ अगर बन जाए तो काफी ज्यादा बेहतरी आ जाती है, क्योंकि जब लॉ होगा तो फिर सजाएं भी मिलेंगी। ठीक है, पहले जो लॉ थे वो पूरा गवर्नमेंट का बना हुआ तो अलग ही है फॉर द प्रोटेक्शन, बट सिंध असेंबली से हमने ये बिल पास करवाया जिसमें डैमेज टू प्रॉपर्टी और हेल्थ के वर्कर्स को प्रोटेक्शन के लिए हमने बिल पास करवाया। 2016 स्टार्ट हुआ था वो, लेकिन 2021 में अल्हम्दुलिल्लाह वो पास हो गया बिल, और अब वो इम्प्लीमेंटेशन की तरफ है। डिसएम्पलेशन उसकी हम कर चुके हैं, जेबिस हमारे तरफ से पार्टनर है, और इसके साथ साथ हम ट्रेनिंग भी कंटिन्यू कर ही रहे हैं, एवरेज वर्कर्स की ट्रेनिंग कर रहे हैं। मीडिया एथिक्स का रोल बहुत ज्यादा है, तो हमने मीडिया पर्सनल के साथ ट्रेनिंग की और उनको भी ट्रेन किया कि इथिकल रिपोर्टिंग किस तरह होनी चाहिए। सो थैंक यू सो मच। That's it.
That was Dr. Adnan Bhutto, the key speaker for the session, keynote speaker. Thank you very much, Dr. Bhutto. With that, I will hand the floor to our discussant, Professor Dr. Mubashir Hanif, the professor at Health Services Academy, to lead the discussion and question and answer sessions. Thank you.
If there are any queries from our senior panelists, if you have some questions, would you like to say something on the topic? There was a presentation on lifestyle intervention. There was a tool used. Then we had a longitudinal examination of fertility and why, in certain age groups, there are barriers towards contraceptives and why that number is low and what are the barriers and what could be the recommendations. Dr. Tariq presented on the health expenditure, when it comes to the economy. So we know that every dollar you spend on health saves a lot in return. Then we had a session on HPV vaccination from Dr. Amber Rizwan, and lastly, there was something about violence for the HCWs and de-escalation of that. So I give the floor to Dr. if you want to say something, if you have a question, if you want to discuss something. I have some points, but I'll keep them to the last.
Sir, they really might have to check us for my
Ji,
comment
sure,
for
sure,
closing remark. And Dr.
Thank you. I would say, first of all, thank you very much for this very valuable discussion on various topics as Dr. have very kindly briefly mentioned all of these. Today's topic, as we are supposed to be discussing universal health coverage and social protection. So I would like to say a little bit on that. First, that the debate around universal health coverage and social protection has gone much beyond combining the universal health coverage or using social protection to achieve universal health coverage. It has gone much beyond, and people have in different areas of the world, we have started to discuss social protection of health. So when we talk about social protection of health, mainly we need to look at health in terms of it's a right of everyone, every individual, no matter what where you are, and no matter what caste or creed or socioeconomic background you are from. But one needs to look at what the key elements of social protection of health should look at. Number one, that it's a right of everyone, so everyone should be provided. Number two, there has to be a range of services available, and several of these presentations actually referred to various types of services that are required. For example, contraception. For example, in case of lifestyle, also the advice on nutrition, advice on the lifestyle, and if somebody has any type of anxieties, what kind of lifestyle they should adopt in order to reduce the burden of that. Then we also talked about the impact of economic spending on health, on the overall economic growth. So all these things are basically in some ways or the other relevant, and especially the economic one is relevant to where in most of the health system, there is no element included on the ongoing care, plus wherever we have social security schemes from the perspective of labor also, the coverage in case of an ongoing sickness, that person during sickness, person suffers from the economic loss. There is no way of covering that. So if we are to ensure the universal health coverage, we have to look at it from a very different angle, and we have to have reforms within our health system in order to bring all these aspects in and try to integrate all of them without any discrimination. We have to adopt the principles of equity and inclusion in order to have all kinds of services and all kinds of the impact of economic laws also integrated into the universal health coverage in order to ensure that our system fully works. Thank you.
Thank you so much. Co-chair Dr. Basharat Bey, आप कुछ कहना चाहेंगे? If you have any, anything to add, or if you have any.
Just wanted to make a small comment on Dr. Ambar's presentation, madam. Since I come from Federal Directorate of Immunization and we are the ones introducing HPV vaccine, I think it will be introduced by 2025, and Dr. Samina is engaged by WHO to work as the national consultant for HPV. So the girls, the target age group for girls is not 9 to 12, it's 9 to 14. So just wanted to make a small. Yes, 9 to 14, madam, and that is for that age cohort is being targeted for the catch-up campaign modality. And as far as the age for the girls, for the routine immunization introduction in EPA schedule, it is 9 years. So just wanted to make a small correction, madam, and I really appreciate the effort because data on HPV and cervical cancer is really lacking. Any sort of data in Pakistan especially regarding the incidence and prevalence of HPV and the and awareness for the vaccine is extremely important for Federal Directorate of Immunization. So any sort of initiative from HSA regarding this is helpful for us, madam. Thank you so much.
Thank you. Bandesha साहब से हमने closing भी करवानी है, but if you have any comments or questions, you're also welcome.
Thank you very much for inviting me, and it was a wonderful session. Speakers actually, they presented genuine data, actually written data, so that was an eye opener in different areas. Especially the cervical cancer immunization was something for me, for a cardiologist at least. But it's an eye opener that we are not working on those areas which really are very important regarding our children's health and for future mother's health and all those. I mean,